suggestive of loss of pregnancy. So I went in with a scissor, a simple 5 French hysteroscopy scissor with rotatable ends, and I went below the residua, gave one cut, allowed the fluid to just balloon that part of the residua which separates the sac from the cavity. Slowly and steadily, millimeter by millimeter, give small snips and a word of caution in case this was one of the first procedures that I did. So in case you find that there is sudden bleeding or hemorrhage, either use a 5 French electrode to quantify, or you can directly switch to an ultrasound guided evacuation. So this procedure does have a learning curve. So as you can see, there were small feeding vessels, and I knew that the moment I cut it, it will cause a lot of bleeding. So I just left that part and went around it, went circumferentially around the sac, and went about finishing the complete uh, excision of the sac. So here, as you can see, the posterior aspect was still a bit stuck. So just open the scissors and push it, push the sac. Don't apply too much force because it is a very delicate tissue. The movement that we do outside is just this with the fingers and the hands. Just this. You don't have to do like this or like this. Don't swipe it all the way around. It is a very delicate wrist movement that you need to do with the entire system in your hand. With this, you can see that we can go fiber by fiber, cut it, and just look at the decidua. Do not go encroach the myometry. So once I thought that the incision was completely over, I shifted to panoramic view, but a small portion of it was still left. So went there with the scissor. As you can see, there was some clouding because of the small blood vessels that were opened up in the process of incision. So I increased the fluid pressure for a brief moment of time by 50 millimeters of mercury above the mean arterial pressure. This gave me a good vision, and the advantage of increasing the pressure is that you can work faster instead of struggling with a lower pressure and increasing the operating time. You can just increase the pressure, have a good vision, finish the good. Now, as you can see, that the entire sac was en bloc completely removed without any spillage or amniotic fluid spillage inside the cavity. So the risk of amniotic fluid embolism in this procedure is less if you can remove the sac en bloc. So next, we have a hysteroscopic evacuation of RPOCs. This nowadays most of our colleagues are doing. Here we can see a small segment of retained products of conception that we can see on the posterior aspect again. Now, many a times after medical termination of pregnancy or even after blind curettage, this is the kind of scenario that we can see. So this patient was a post-surgical curettage patient who had come to my center for continuous spotting for the last 12 to 15 days. So we went within with the hysteroscope. Again, the trustworthy scissor. So scissor is one of the most versatile and most useful instrument in hysteroscopy. Yes, there is a place for the hysteroscopic shaver and morcellator, there is a place for resectoscope, but in fertility sparing surgeries or fertility enhancing surgeries, the less amount of energy you use, the less amount of complicated or complex instruments you use, the better. Because the amount of damage that can be done by a machine, which can be uncontrolled sometimes in some cases, can be avoided when you use a small mechanical scissor. A scissor of 5 French will cause a damage of less than a millimeter. So here you do not have a lot of degree of causing a iatrogenic injury specifically. Even if you want to try and injure, there will be a less chance that you injure. So now, as I was saying, yes, there is a place of resectoscope. So this again was a case of uh, uh, no, MPP. For this was actually an evacuation for early pregnancy loss. Here, as you can see, there was a big clot, and then you can see a good gestational sac. But again, changes of necrosis, areas of congestion can be noted. So here again, now in this one, as I progressed with the procedure, I started using vasopressin at the base of the that set up with my mighty and trustworthy scissor and went about circumferential incision of the respiratory sac as I had shown in the first video. After complete removal, yes, there were some parts which were not being easily removable with a scissor. So the scan of this patient showed that she had adenomyosis and this implantation was on that adenomyoma. And hence the residue was densely level. Here I am not using any energy. Even though it's a bipolar resectoscope, I am not using any energy source. As you can see here, yes, this was the point where it was densely and it adhered and very thick. It was difficult to cut with scissor and it would have taken a very long time. So here I am using the resectoscope actively. Although we have a passive resectoscope where we pull in the tissue, here I am pushing in the tissue because I am not using any energy. It is safe to use it. Although an obstetric the pregnant uterus is very fragile, you have to be careful not to apply a lot of force. Just gentle scraping done, and all you can see is the bilateral fibers without excessive irritation of development of the bilateral fibers. So with this, you can what actually we do is cure that they got strips of endometrium. So this process is similar to PCRE or curettage, but without the use of energy. So here we see a completion of this procedure with complete evacuation. The residual tissue has been completely removed, so the chances of bleeding or intrauterine infection or assailments will be on a lower side as we have done a good job with good vascularity as well. So with this, I end my presentation and I thank you all for a very patient hearing.
Thank you, Amok, and especially for highlighting the role of uh, microhysteroscope and office hysteroscope, because that avoids the trauma to the cervix, and we can avoid dilatation, and many a times we can avoid anesthesia also.
Right, sir.
Uh, you had excellent cases, but I would like to just point it out that in retained products, even many times the sonologist would mention high blood flow in that area and all those things. But you can go ahead and evacuate it even with a grasper also. You just keep pushing at the base and it keeps on getting detached. With scissors, you will still leave behind some tissue because you won't be ever flush to the endometrium.
So that is why I use a cold resection with a loop. So it
Yes,
works as a
so
tubet.
even with a big grasper with a serration inside, you keep an open grasper and push, not gripping the tissue. Otherwise, once you grip, it will break off.
Right.
The tissue will break off. So keep on pushing along with the, and I mean, at the level of endometrium, it keeps on getting detached because these are detachable tissues. Okay.
So, but what we have experienced in the recent past is that when the implantation takes place on an adenomyoma or adenomyosis,
Okay.
even with the biopsy forceps, it is very difficult to push it. Even with a scissor, you cannot cut that RPOC. So you
Agreed.
require something strong or a larger instrument to remove that. So that is why in few cases I
See,
used to use a 26 French resectoscope.
those you require energy and resectoscope. Okay. That is a special case by itself. These are very uncommon cases, but in general,
So
this is
unfortunately,
what I'm.
I have had out of last 10 cases, I have had 7 cases of implantation of adenomyosis.
Wow. So you have a very special group of patients. That adenomyosis person getting pregnant and then getting. Anyway, nice presentation.
Thank you, sir.
Rajendra, comments from you?
I see Amod, congrats with a nice presentation. Only thing if when you do, I could say it would be correct to some extent to do removal of retained products of conception when your conventional methods have failed. You know, but about the termination of pregnancy, especially in smaller gestational age, with directly with hysteroscopy, is it if possible whether everybody should adopt to that particular technique is a question because you are a good hysteroscopic surgeon. You will as a surgeon you will have watch on everything such as uh, am I audible properly?
Yes, sir. Yes, sir.
So you will be able to watch because you are consistently doing hysteroscopy. You can look after the fluid. You can look after when the fluid is getting over, whether the bubbles are getting introduced. And pregnancy is a state where it's very hypervascular uterus, and there's a lot of fluid absorption takes place when you distend the pregnant uterus.
Right, right,
Requires little more pressure to distend as compared to a normal uterus. In that process, you may use a lot of normal saline may get absorbed, and you need to check whether when you do this procedure, if the patient may land infection, bleeding, or fluid overload, whether then retrospectively are you justified to do this procedure when it comes
right,
to legal problem.
right. So, sir, to avoid the problem of fluid overload, I use vasopressin, and I finish the procedure within 10 to 15 minutes. So that vasopressin effect for 25-30 minutes reduces the fluid absorption through the cavity. So that is one thing that I've started doing because in the earlier procedures I did have one or two cases where there was some amount of fluid overload, but Lasix was given, urine output was monitored, all monitoring done in ICU as well. And as I started doing more and more cases of hysteroscopic evacuation, especially for a missed abortion, not for an MTP, but for a missed abortion or an RPOC. That time, yes, there are changes that I am doing to the procedure as well, and it is giving us a good deal. Most of the patients after evacuation are conceiving within 2 to 3 months of the procedure without any medication. Patients who had conceived after IUI or are this thing stimulation with plant relation, they conceive naturally after the procedure.
Correct, correct. Only
No, that is true, but with an intake pregnancy, the blood flow is more. So the
Yes, yes,
intravasation would be more. In RPOC or missed abortion, the blood flow is relatively
yes.
much lower.
So,
But
so
I would put a word of caution in using vasopressin. If you have an anesthetist who is there, patient is intubated, then only use vasopressin.
so all my
Okay,
cases are
most of the
intubated, especially
hysteroscopic
for evacuation.
even the short hysteroscopy procedure, you
Yes,
do it under GA,
yes,
full
yes.
GA,
Full G.
because so many times I'm doing it even without anesthesia.
Yeah.
This kind
I
of thing,
so all my
RPOC,
procedures are
because the
full G.
cervix, the pregnant cervix is anyway very soft, so
Yes,
it's
yes.
not very tough to pass the scope inside.
Right.
Because we have seen complications of vasopressin, the cardiac effect and
Yes.
sudden hypotension and all those things. So vasopressin, use it, but with a word of caution, and more so in pregnant uterus where the pelvic blood flow is high and intravascular injection is likely.
Right. Right. Sir, another thing about hysteroscopic evacuation with morcellators and shavers, it is going to be all the more easy for missed abortion and RPSCs because the time of the procedure will be cut down drastically to less than 5 minutes, 6 minutes.
I think Amol, your way I mean, you showed the video which was very simplified because of your skills. But I think it requires audit of your cases. How many cases you did because it involves a complete general anesthesia. It involves operative time and also sometimes an injection vasopressin which may have some side effects. You know that very well and fluid overload.
Right,
So
sir. Right.
for doing this procedure, there is a conventional way which is available, which is little, more easier for everybody to learn, and everybody goes to their residency.
Right.
This
Right.
would really require evaluation in terms of the number of cases, time required, and all complications you must have. So you will have a valid reason that okay, this looks good than the conventional way. Whereas
Right,
Dr.
right, sir. So now, when I started doing it, there were hardly any papers available for this procedure supporting the hysteroscopic evacuation. Now, I've went through almost 20-25 recent papers which said that hysteroscopic evacuation for missed abortion and RPOC is very safe. And most of the papers now, the 2023 and 24 papers, they were for the hysteroscopy shaver and oscillator.
Cystoscopic removal of RPOCs, there are hundreds and hundreds of papers
Yes, yes.
justified about mixed abortion
Missed abortion, yes.
and see visa requires really an audit for this procedure.
Right, right, sir. Right.
A wonderful presentation.
Thank you, sir.
Thank you. Let us move on to the next one. And
So,
I saw for a brief moment Subhash here. Subhash, is he still with us or has he left?
Subhash will join back, and Dr. Ramesh is unwell, he's not joining. And Parul,
Uh-huh.
not there. Dr. Subhash will chair and will be assisted by Dr. Latika after she's finished her talk.
Thank you. So I may move off. Okay. While the presentation is on, anytime I may go. Please excuse me because I have that meeting of ICOG annual conference in Ahmedabad Society. Okay, please, the next one.
So the next speaker is Dr. George Paul, and he speaks on parasitic myomas. Dr. George Paul is a consultant endoscopic surgeon at Paul's Hospital, Kochi. He's a scientific coordinator of the Cochin Gynae Endoscopic Training Center in Kochi, and he's an ESG Bachelor in Endoscopy, European Academy of Gynecological Surgery, Belgium. He's a FOXY Endoscopy Committee member from 2021 to 24, and he has been invited as a faculty for various national conferences and surgical workshops, and he has also been awarded the IG Young Skin Excellent Start Award. So the floor is yours, Dr. Paul.
Thank you. Thank you, Dr. Pashali. I'll just share my screen. I hope I'm audible.
Yes, you're audible.
Okay. So we have a simple topic. So I'll be talking about parasitic myomas and the importance of in-bag moscillation. So parasitic myomas was first coined in the year 1909 by Kelly and Cullen. Parasitic myoma is basically myomas caused by the seeding of portions of fibroid remnants that occurred during moscillation at the time of myomectomy or hysterectomy. The incidence, according to the literature, is about 0.9, but it's almost impossible to identify the actual incidence, as many go undetected because many of these patients, they come with very vague symptoms. Some may not even have any symptoms at all. By 1991 is when SEM developed the laparoscopic hand modulator. By 1993, electromechanical modulators came into the market. And soon after, by 1997, is the first case of parasitic myoma recorded in the literature by Ostrensky. Within a few years, even we faced some parasitic myomas. This was a image article that we published in 2006 in Fertility Sterility. But in fact, the actual surgery was a few years earlier. I think it was the early 2000s. So incidence of parasitic myomas has been on the rise from the beginning itself. And as we've been doing more and more cases, we've seen more parasitic myomas. This was a recent publication, image article, a case report that we had done in 2018. Some of the factors that affect the growth of parasitic myomas are gonadal steroid and even progesterone. The diagnosis is usually the difficult part because they may not come to you with any particular symptoms. Some of them may come with pain, dyspareunia, pelvic pressure, some sort of abdominal pelvic mass, and any mass separate from the uterus. If you're seeing that on imaging, and if the patient has undergone a previous lap myomectomy, you should always think about parasitic myoma. So this was a case. In fact, we had operated on her thrice. This was the first surgery in 2011. She had a 9 centimeter myoma, and this was the time where we were doing uncontained moscillation. We didn't really expect the incidence of parasitic myoma becoming so big. So this was the time we had during time we were doing uncontained morcellation, we enucleated in a traditional way. We use an harmonic, and then we sutured the myometrium with barb suture without much difficulty. And here you can see how the myoma is being morcellated. So this was sort of the beginning. So the skills of morcellation is also sort of developing. And no matter how skilled you are, inevitably pieces will get thrown away. And sometimes it just keeps spinning on the blade as well. See, as you can see right now. So these are all situations because of centripetal force, pieces gets thrown away. And as much as possible, we try to pick up all the small remnants of pieces that got thrown away, and we retrieve them as much as possible. But then again, in 2015, she came with heavy menstrual bleeding, and this time we were planning a total hysterectomy. And as you can see, numerous small fibroids scattered along the surface of the uterus, along the this is along the UV fold. There are smaller pieces on the peritoneum as well, along the abdominal wall. So the hysterectomy part was pretty much the same uh, as a traditional hysterectomy. I will skip that part, and we went ahead with removing all the other small myomas as much as possible. Then later in 2020, she was 42 years old. She came with a vague abdominal pain, and MRI showed multiple masses and one as large as 8 centimeter. So then we went in again, and this is the current. This was the picture. Again, you can see the small studded myomas along the abdominal wall. This is comparing to 2015 and 2020. So we were releasing all the small adhesions along the from the vault, uh, and we were releasing the ovary as well from there. And according to the MRI, there was a mass on this side. You can see here. So this was a globular parasitic myoma. We were releasing all the flimsy adhesions. Uh, you might you'll have a tendency to underestimate the vascularity these masses take in. So you have to be quite careful when you dissect, because it could have a very vascular pedicle to it. So when you're dissecting, use your bipolar, your harmonic. Don't just try to pull it out of the area where it is adherent. So this was relatively easy. We took out that piece. So in total, I think we took about 7 myomas. This was the first one, myoma number 1, and then another small one along the rectum that was taken out. Since we were expecting multiple ones, we put in an endo bag just so that we can collect these myomas into the bag and not lose them. So this was towards the liver side, taking vascularity and attachment from the omentum and the transverse colon. So these ones are quite dangerous usually because of the vascularity. I'll show you another video also where we had a difficulty in doing that. But this was again, you have to take your time and dissect it carefully, coagulate the vascular areas, and then separate it from the transverse colon. So that was the third myoma, dissected that. And then, yeah, oops, sorry. And that's the fourth myoma. We got it just above the liver. Again, other smaller ones. In total, about 7 myomas were taken, and then it was morcellated in back. This was another case. This patient had undergone lab myomectomy in 2015, and now she has come back with a large mass palpable up to 28 to 30 weeks. And the MRI showed multiple large masses. So these videos, I would just like to show the incidence, the actual incidence. A lot of people still do uncontained morcellation, saying that it doesn't cause parasitic myoma, and there's a lot of debate regarding leiomyosarcoma as well. But in my topic, my scope is only about prevention of parasitic myomas. So this was the 2015 surgery where we had done again uncontained morcellation. You can see the various pieces scattered all over the abdominal cavity. And this is 2022 with a huge mass. In fact, that is the mass that you're seeing, and you can see the uterus, which is completely normal, very innocent looking in the pelvis, and that is the vascular pedicle, giving the vascularity towards uh, parasitic myoma. So initially, I was a bit too adventurous, and I ventured, and it started bleeding. So in these situations, using instrument like ligashore or properly using your bipolar really makes a difference. This is another case again, as you saw the image. Uh, this patient had undergone a myomectomy before, and these were two parasitic myomas, one taking vascularity from the or attached to the anterior abdominal wall, and one along the side. So this is me separating the parasitic myoma. With all these large ones, it mostly will have a large vascular pedicle. So that is something that you have to be careful about. I know that I'm repeating that multiple times because that is something that you tend to underestimate at times when you do surgeries like this. So this patient, we were doing hysterectomy as well. So we went same way. Hysterectomy was pretty much straightforward. Again, you can see bunch of grape-like myomas hanging from the uterus as well. See, it's not that all patients would have, but some of the it's a sort of inborn or like a tendency that the patient might have, and some of these patients might even have the pathology might come as cellular leiomyoma as well. So those are ones which has a higher tendency of parasitic myomas. So myomectomy was done. So since you were doing this along with myomectomy, the specimens were taken through the vagina. So now a lot of people are questioning about vaginal morcellation as well, whether we should do that within a bag or not is also a big question nowadays. So probably with situations of parasitic mamas following vaginal morcellation also, I think eventually we might end up doing that as well. So comparing open and contained, I think it was pretty much evident with the videos. Using a bag, another advantage is that you sort of prevent any risk of injury to the adjacent organs and soft tissues. We had done a review of literature of the various methods of tissue retrieval. This is a literature done in current obstetrics and gynecology report. So one such bag developed by the Indian team is the MOSAFE bag. It has a large opening through which the mocellator is inserted and the myoma is mocellated. And you have the eyepiece through which the primary trocar is inserted. So there have been various bags available. This is another bag developed by an Indian company. So I'll just show you how it is easily inserted. So we normally put it through the suprapubic port, mainly because the lateral port sometimes after closure, it sort of entraps nerves and causes pain. So we normally do it through the suprapubic port. I I enlarge the wound, use a dilator to dilate it slightly, and nowadays we normally use a 15 or 18 mocellator for large myomas. So this is another bag, not massive, another bag. So introduction is quite easy. So I just push it along with its introducer through the suprapubic incision. You can see the picture in picture how it comes inside. So once it is inside, the introducer is just rotated anti-clockwise, so it loosens up, and you just pull out the plastic bit that is the introducer, and the bag will be completely inside. So once the bag is inside, what you do is you hold on to the eyepiece and just unroll the entire bag. So this was a case with multiple large myomas. I had already done the myomectomy and everything. So I'm just showing you how it is introduced into the bag. Very large ones, you may have to use a tenaculum or myoma screw to hold on to the myoma and bring it into the bag. And once the myomas are inside the bag, it is pulled out through the suprapubic trocar. And the eyepiece, what I normally do is I'll railroad it into the primary trocar. pull it out through that incision and reinsert the primary trocar through the eyepiece. And the myomas are morcellated within the bag. So this is one of the article my father had published. This is quite a few years back. This was the first one when we had used mosaic bag. So the specimen induction time was about 12.5 minutes. The morcellation took about another 25 minutes. But with repeated use, as you get more and more experienced, right now I probably take less than 5 minutes for introduction of the specimen, introduction of the bag and the specimen into the bag. Morcellation again with the help of 18 oscillators, you can significantly save time. So things to think about is that the actual incidence of parasitic myomas are much higher. So you should always try to practice in-bag morcellation, not to prevent leiomyos upstaging of malignancy, but to prevent parasitic myomas. And with experience, you will reduce your time in doing the surgery, and spending that extra 10-15 minutes is always better than doing a repeat surgery. So thank you everyone for listening to this talk, and thank you once again, Basketball sir. Thank you.
Thank you, Dr. George Paul, for this excellent presentation. As Dr. Parul Kotrawala sir has left, requesting if Dr. Rajendra sir or Dr. Bhaskar Pal sir would like to put in a few words.
Yeah, I think we talk of leiomyo, the whole morcellation bag issue came up because of the leiomyosarcoma issue. But I think leiomyosarcoma incidence is about 1 in 1500. And somebody who's at a fibroid for ages, sarcomatous degeneration actually doesn't occur. Most leiomyosarcomas that we see are de novo fibroids, and that is where we can select our cases properly. But the main reason for doing an in-bag morcellation should be the prevention of parasitic fibroids. All of us, when we get cases from our days of naked morcellation and we do them on laparoscopy for any other reason, we see this. In some cases, we see myoma studded all over the abdominal wall. So I think the main take-home point, I think George has highlighted about taking the pedicle in the parasitic myoma. But I think we should try and do a contained morcellation essentially for the reason of preventing parasitic myomas. And we should, of course, for preventing leiomyosarcoma spillage as well, but those cases we can select well.
Yes, so that is something which is beyond our control. During enucleation itself, we are sort of upstaging it. So I think what we should focus is about parasitic myomas, and now we are seeing more and more incidents of myomas, and everybody is morcellating. So definitely the incidence is going to go up, and is something that we have to keep in mind.
Hello, yeah.
Rajendra, can you move closer to the mic, please?
Yeah, can you hear me?
Yeah, we can hear you.
Yes.
George, it was really a nice presentation. There are two things of caution, like as Dr. Bhaskar has already mentioned, since 2014, this issue has come to prevent the spread of leiomyosarcoma. This is the case which has happened in United States in 2014. There are two things. One is, especially we have to be cautious about doing myomectomies in younger age group. Very young age. I have seen women with age of 22 years with multiple large fibroids. You have to justify your surgery laparoscopically when you do a laparoscopic myomectomy, especially for multiple large fibroids, number of fibroids, because irrespective of your skills, the amount of time which will be taken for the surgery, it depends upon the large size of the myoma, the depth of the myoma, and location. So whether, because myomectomy involves three steps: one is enucleation of myoma, suturing of the defect, and morcellation. And now add-on thing is putting a bag and in-bag morcellation. You must do in-bag morcellation for each and every fibroid, irrespective of their age group. Not only to upscale the malignancy level, but also to avoid parasitic leiomyopathy. There is a place for laparotomy as well we must consider. Because if you choose a patient with a very large fibroids, I have seen people doing a 28 weeks, 30 week size multiple myomectomy which probably may not be a correct way of doing just because everybody knows laparoscopy. There is a place for these patients when you do a laparotomy, myomectomy, you will probably reduce the chance of parasitic leiomyoma. There are two entities. One is parasitic leiomyomas and peritoneal leiomyomatosis. There are two different entities. Some
Those are
patients are,
spontaneous.
yeah, more prone to have a tendency to have peritoneal leiomyomatosis. It is a entire different entity where peritoneal smooth muscles can produce fibroid. When you do myomectomy, especially which you showed larger, you need to counsel this patient irrespective of your skills. Probably they might come back with all these problems, irrespective of using the bag. Patients do come with the peritoneal leiomycosis. This
Yes.
was a good presentation, but all youngsters always look. I mean, I feel there is a place for laparotomy, myomectomy, where you can open up the patient and remove all fibroids in 1 or 1.5 hours with a very much reduced blood loss and avoid future complications such as the parasitic leiomyoma. In all, it was really a good presentation. Thank
I
you.
totally agree with you, sir, because even what we do when we have multiple large myomas, we do a sort of like a mini lap incision of about 5 to 6 centimeter. Initially, we just put a myoma screw and then extend that incision, pull the myoma out, and then we start enucleating. So, like you said, we save a significant amount of time and
Right.
energy.
In
And
laparoscopy, in gynecology, we operate patients in Trendelenburg position. Endo is given, and if you operate more than 3 hours, a lot of changes happen intracranially, hypothermia, embolism, deep vein thrombosis, all these problems should be considered. I have seen surgeons operating from 9:50 to 6 o'clock just because they wanted to remove the fibroid laparoscopically. It may not be a correct way of doing it. So
yes,
I see WhatsApp group, somebody puts up a bowl full of fibroid and saying, I removed a fibroid of 2.2 kgs. Today, currently after 2 minutes, there will be another post. I removed 3.5 kilogram fibroid. I removed 34 weeks fibroid. It may not be a correct way of doing it. I think we are putting the patients in risk for some time. Yeah, that's what I feel.
yes, sir. Thank you, sir.
Thank you.
Thank you, Dr. Sankpal sir. Thank you, Bhaskar Pal sir. So from now, and thank you, Dr. George Paul. From parasitic myomas, we now move on to laparoscopic total peritoneal single pedicled flap vaginoplasty for gender affirmation surgery. And to give a lecture on it, we have Dr. Latika Chawla. Hello, Dr. Latika. May I have a CV, please? So Dr. Latika is a consultant gynecologist and endoscopic surgeon. She's an endometriosis excision surgeon of Mumbai. She has a fellowship in advanced minimal access surgery in gynecology under Dr. Rakesh Sinha, Mumbai. She has specialist training in endometriosis surgery from India, UK, and France. She's an international Vatikuchi scholar in robotic surgery, awarded by the RSCOI in 2016. She has been a clinical examiner for MRCOG examinations. She's a faculty for training in laparoscopy at IIM Mast, Mumbai, and Royal Stoke University Hospital. And she has various accolades to her credit. We welcome you, Dr. Latika. Please carry on.
Thank you so much, Dr. Paushali, for the very kind introduction. Am I audible?
Yes, you are.
I just will share my screen. Can you please allow screen sharing? I'm not able to share.
Not sure. Yeah.
Yes, yes.
Shruti,
Okay.
ফাইলটা খুলে একটু চেঞ্জেস গুলো করে নে। তোর কাছে ফাইলটা আছে তো ডেস্কটপের, ওটা এখানে আয় না, তো ওয়েবিনার চলছে।
At the outset, I would like to thank Dr. Bhaskar Pal sir, Dr. Paushali, and the entire team of ENDOVISION for giving me this fantastic opportunity to be able to present something in front of all these stalwarts and my very talented colleagues. I know I'm stepping onto some controversial territory here, and I would love for my seniors to give us some inputs and understanding for this technique. Today I'm presenting on the total peritoneal single pedicled flap vaginoplasty for gender affirmation surgery. So we are discussing today male to female gender affirmation surgery. As we do know that penile skin inversion is a standard surgical technique that is used for most male to female gender affirmation surgeries. The total peritoneal pedicled flap is nothing but a modification of the standard Davidoff procedure, as well as the pull-through vaginoplasty that is being done for MRKH. As we have performed these surgeries over a period of time, we realize that the role of these surgeries is mainly in redo procedures and for transgender women that are unable to undergo a penile skin inversion. We are seeing more younger patients coming up with gender dysphoria and requesting surgeries at an earlier stage. In those cases, sometimes the penile tissue is not, completely developed, and even for those who have penile hypoplasia, primary penile skin inversion surgeries can actually not be good modalities for this kind of a procedure. Why do we ask to get peritoneum in these surgeries? It's most important because peritoneum is moist, it is expansible. You can procure as much peritoneum as you need to line the neovagina. It is non-hairy like penile skin, and it does evolve into a stratified squamous epithelium as time evolves. It also has innate functions of absorption and secretion, so it's able to provide good wetness to the neovagina and enhance the sexual experience. Why do we want a single pedicle flap? There is enough literature that's available that tells us that we can harvest a flap from the peritoneum, get it down, and just line the neovagina, and that makes life easy. But why do we want a pedicle flap? The pedicle flap has its advantages of obviously having a better blood supply. Most of these pedicles are based onto the inferior epigastric vessels, which is why the vascularity is very good. Pedicle flap is able to give us a deeper vaginal length. Now, no matter what technique you use to create a neovagina, some amount of apical fibrosis does occur. So, if at the end of the surgery we've achieved, say, a vaginal length of 6 inches, 3 months or 6 months from that time, the vaginal length will reduce to about 5 inches or 4.5 inches. And that is the way that healing occurs. So, it's true for almost any technique that we utilize for developing a new vagina. The single pedicle flap gives us better aesthetics. There is a lot of data on these pedicle flaps that are then exteriorized from the iliac region and brought out in the groin to create a flap. But these do leave a lot of scars in the groin area, which is not cosmetically very viable for these patients. I have tried to concise the video and I'm going to try to stop at some key points so that we can discuss them at length. As you can see in the beginning, I've marked my incision. So the first particular thing that we do here, first step, is to mark the incision. Usually where you mark your incision will depend upon the length of the lower segment. That is the distance between the umbilicus to the pubic symphysis. In patients that have a smaller, lower segment or a infraumbilical area, we need to even go supraumbilical in these cases. The only disadvantage is that there are greater chances of buttonholing as you keep going superior because the peritoneum is extremely thinned out. And when you try to dissect the peritoneum too much, you create a lot of buttonholes. The idea here is to always remain beneath the plane of the median umbilical ligaments. As you can see here, the umbilical ligaments are seen very, very clearly. We make an incision around the level of umbilicus here. I have taken two left lateral and one right lateral 5 mm port for dissection. In areas where the peritoneum is extremely thin, I am not utilizing any electrosurgery because we do not want to compromise on the vascularity as much as possible. As you see here, the peritoneum is extremely thin, and especially when we are cutting it off from the fascia, we have to be very careful about not taking the rectus sheath, the fascia along with the peritoneal lining. If we use instruments like the ultrasonic scalpel, we have more advantage of the cavitation effects. It helps us opening the preperitoneal planes in this case. And the intra-abdominal pressure here, I've kept around 10 millimeters of mercury because if the pressure is higher, then it doesn't allow us to give a counter traction to pull the peritoneum down while we're dissecting in the plane. After dissecting on the left-hand side, I have repeated the same procedure on the right side. The idea is to get at least 20 to 25 centimeters of peritoneum. because we are going to turn this peritoneal flap and push it inside the neovagina in the steps to follow. The second most important dissection here is the lateral dissection, which is at the triangle of doom. Now, as you see here, I am dissecting in the area of the triangle of doom, which basically is lined by the internal spermatic vessels and the vas deferens. And we want to make sure that we stay away from the iliac vessels. And as we go down, we also lateralize the ureter. We are able to look at the ureter from the intraperitoneal aspect when we are dissecting. Centrally, when we dissect, we reach at some point at the dome of the bladder. Now, this was why I was saying it's important to remain below the median umbilical ligament, because if we are going in the plane behind it, we will end up going into the space of Retzius and dropping the bladder off, which is not what we want to do. We want to remain anterior to the bladder. Here, we were looking for the ureter and defining the course of the ureter. Now, the ureter, once lateralized, will only enter the bladder in the extreme posterolateral aspect. So, till then, we are safe. We do not have any major vessels as well as the ureter. The third part of the dissection is the dissection of the peritoneum of the bladder. Now, this is the most tedious part of this dissection, because the peritoneum over the bladder is quite well applied to the bladder. So we do not get a very easy plane for dissection, and we have to be very careful, make sure we are not away from the bladder musculature, and dissect in very short bursts. I am using the bipolar shearer here because I'm more comfortable with that for dissection. And any small bleeding can be taken care of immediately. But yes, very important to be careful here so that we don't cause any damage, thermal injury to the bladder. Now, once we come lower down, we are going to remain only central because, like I said, the ureter enters from both sides. The plastic surgery team in our case was the one that was doing the dissection from below and created the tunnel from where we create the neovagina. Now, once the intraperitoneum is entered, we do blunt dissection to extend the entry, and a silicone dilator is inserted from below, and this is how it looks. Now, usually we will take the two ends of the flap that we've created and we will just give it, through the neovagina. We'll feed it through the neovagina to the outside. Now, I'm just going to stop for a bit here because, oh, I'm so sorry. So this particular flap that you see here, the red flap, is actually the part of the urethra. So whenever penile tissue is cut, the penile urethra is longer than the female urethra. So keeping about 3 or 4 centimeters length that we actually need for the urethra, the rest of the urethral tissue is harvested. And the urethra is opened, turned and inserted into the peritoneal cavity. So the anterior part of your neovagina will be lined by the urethra. So this is the anterior part that I have received, and on the other 3 sides, I have the peritoneum that I have harvested. And now I'm going to take sutures to close sutures to attach the urethra to my peritoneum to create a tunnel. So we take continuous sutures using Vicryl number 1 in order to create a tunnel on both sides. Now we are above the levator ani here, so we are able to gain about 2 inches extra from above the levator ani, which is why we are able to provide better depth at the end of the surgery. So after suturing on both the sides, we also try and go higher and take a nice purse string suture from the urethral tissue anteriorly, from the peritoneum laterally, from the serosa of the sigmoid posteriorly, and keeping the silicone mold in situ, we close the apex of the neovagina. Now, this silicone mold stays inside for about 5 days post-op, after which will be the first time where we will take out the peritoneum, the silicone mold, flush the cavity to take off any kind of slough that is there, and reinsert the silicone mold. Here I'm taking the purse string suture. Now, initially, when we started doing these surgeries, we were placing, interseed to cover all this raw area that, is left behind when the peritoneum is cut off. But later on, we realized that the peritoneum really grows very fast. And after that, in the last few surgeries, we've not left any, adhesion barriers. Though I want to say that we have not gone back to really see whether any adhesions have happened or not. So that still remains controversial at this point. So once we close the cavity, this is how it looks. So we do call these patients in for a follow-up, and at 21 days, we want to see how the cavity looks. So if you can see with the minimal of slough, the peritoneum or squamous metaplasia has already started happening. And when we look at these patients 3 months later, the entire squamous metaplasia is complete, and there is stratified epithelium that develops in the vagina, and it actually feels also like normal vaginal tissue. This is a 3-month follow-up. Now, this was one of the IVPs we had done for one of our patients who had some urinary troubles, and we wanted to rule out any kind of thermal injury, which is why we have a film for that available. But this is the external view, the complete credit of which goes to the plastic surgeon team I operate with. The advantage here, like I said, is when you see that there are scars, usually when pedicle flaps are taken in the groin, large big scars of 4 or 5 centimeters on each side. And as you can see here, because we have completely extraperitonealized, gone behind the bladder and pedicle, use the flap internally, we have not come out anywhere, and it gives very good aesthetics to the patient. I want to discuss a little bit about our experience so far. In the last 7 years, the team that I've been operating with has been doing surgery since 2017. I have started operating with them only in the second half of 2020. These 53 patients underwent gender affirmation surgeries. The average hospital stay was for about 10 days. Now, the duration of surgery was 6 hours to 14 hours. Now, most of the laparoscopic work is over in maximum of 60 to 90 minutes. It is the plastic surgery part, the vaginal part, that takes a longer period of time. Now, initially, when we were doing these surgeries, we were giving patients complete general anesthesia. And a few of these patients, of course, if you give them general anesthesia for such a long period of time, the morbidity was higher. So, in the last year and a half or so, we've started doing, the initial vaginal part under spinal epidural, after which we give general anesthesia only to do the laparoscopy part. So the definite GA time has reduced. We've had local hematoma, about 3 of them till now. Loss of cavity length in about 6 patients, and most of these were because of loss of post-operative dilatation, which also I will discuss. There was one bowel injury that actually happened during self-dilatation on day 9. One single ureteric injury, as you had seen that the part where we go behind the bladder, and we're taking that incision and opening the new vagina apex. We were doing that initially using thermal energy, and that was one of the patients that had a delayed thermal injury. But after that, touchwood, things have been fine since we've been doing blood dissection. And we did have some peritoneal flap loss as well in one patient. And most of these patients who are smokers, who are anemic, who are seropositive, those are the kind of patients where the vascularity is already compromised, and pre-operatively, they are also counseled about the implications of loss of peritoneal tissue. If we were to critically evaluate this procedure, I mean, at the end of most of these surgeries, our entire team sits down and we think of what we can do better and what is it that we are not doing well in these cases. We have realized that because of the morbidity of these cases, with the role in primary, gender affirmation surgery, I wouldn't say is there as yet. We are still refining our technique, and we do explain the patients that there are simpler techniques available if you are ready to compromise a little bit on the vaginal depth. Operative morbidity versus gain in depth. We do gain at least 2 inches more than the conventional techniques, and patients who especially have had failed previous surgeries want better depth, and they are okay to accept this technique. As I said, that we are trying to reduce GA time by doing most of the procedure in the spinal epidural and then only doing the laparoscopy part in GA. Post-operative dilatation has been a challenge because we are going above the levator ani, there is a tendency to generally contract the pelvic floor muscles, especially during dilatation. In the initial first 2-3 months, patients feel pain and they are not able to dilate well. After multiple permutations, combinations, we have started using diazepam suppositories, which was suggested to us by one of the urologists we were working with. And a few of the patients, we've used it only in 2 or 3 patients till now, but they do have, they've had some benefit with that. They're able to relax their pelvis better, pelvic muscles better. And we also have started doing pre-procedural pelvic floor relaxation in these patients. So 2 or 3 months prior to surgery, we introduce them to what pelvic floor muscle relaxation is, and we make them do those exercises so that they don't really are ending up doing that for the first time after surgery. Also, we can divide the flaps. We can make it into a double flap where we don't need to do the entire bladder dissection. We can have the intraperitoneal, apex like we do in a general MRKH pull-through surgery. The only disadvantage in that is probably again a little loss of vascularity in the flap. But yes, we have used those techniques as well in certain patients where the morbidity is higher and the bladder dissection is not easy. To err on the side of safety, we have taken double flaps or even a urachus to peritoneal flap, where we stop at the dome of the bladder and we hinge the flap and take it inside the neovagina. There is some data available. There is one very good, systematic review, which has been published, in our Royal, Australian Journal of College of Surgeons, which has studied about 470 odd, articles which have been published on use of peritoneum and neovagina. And as far as we know, that this single flap pedicle technique without a, groin incision is not being practiced or published so far. There is a clear advantage of using the peritoneum over the other techniques. Thank you, and I want to acknowledge the team of plastic surgeons I work with, Dr. Umang Kothari, Dr. Nitin Gav, Dr. Nidhi Khandelwal is my co-surgeon. She's a general laparoscopic surgeon, and Dr. Renu Ranka, who's our anesthetist, who really puts in a lot of effort because these are really long surgeries. At the end, I would really like to thank Bhaskar sir once again, and I would say that, I really would seek your support for his, candidature. Sir has been an excellent mentor, and I think when I look at him, I feel like there is a very bright future for juniors like us because the kind of support, unconditional support Sir gives us is amazing. So all the best, Sir, and we hope to see you and and work under you. Thank you so much.
Thank you, Latika. Wonderful presentation. Rajendra and Subhash.
Dr. Latika, it was a wonderful presentation. Right, it's a different technique from what we normally do. May I just ask Dr. Surakshit to just open his video? Dr. Surakshit, are you there? Yeah, hi. Dr. Surakshit, you also do a different technique from what Dr. Latika has shown. So what are your takes and what is your take on this?
I think it's pretty much the same. Only thing is, I think as Dr. Latika is saying, the post-operative is the most complicated part. Most of these patients do not do the dilatation, and then it becomes a big challenge for us. So I think that is what is a main challenge in all. I think technique-wise, it's all fine. I just think that post-operative, we should really focus on the post-operative part first. In fact, I tell all my patients first, just if you're okay with the dilatation only, I will do this procedure. Otherwise, I'm not going to do the procedure at all.
So as Surakshit has rightly put, it takes a lot of counseling. We do a lot of counseling, we do tell, but at the end of the day, the patients don't. Because they fail to understand the importance. Ek baar surgery hua to hua. So that is the sort of attitude which these patients have. So most of the times that we have this issue with us, right? Anyway, Latika, thank you very much. If there are no more questions, can we go to the next one, Paushali?
So thank you, Dr. Latika, for this excellent presentation. Our next speaker is Dr. Nayanika Gaur, and her lecture is on ectopic pregnancy, laparoscopic management. It's actually a compilation of video presentation of ectopic pregnancies at various locations. So Dr. Nayanika is an IAG Young Skill and Excellence Award winner. She has an IAG Youth Icon Award awardee, and she's a managing committee member of the IAG Rajasthan chapter. She's an endoscopy trainer for Eagle Project, and she has various publications in PubMed journals, with experience in gynae endoscopic surgery for over 10 years. We welcome you, Dr. Nayanika. Please go ahead with your presentation.
Thank you, Dr. Pashwani,
Nanika,
for
it's a pleasure to have you, and it's
Good
a short
evening, sir.
notice. And over to your talk. Thank you.
Good evening, sir. So without wasting much time, I would share my screen first. So this is a partially recorded presentation. So I will use this directly. I'm not sure. Is my screen visible?
Yes, it is visible.
Yes, Nanika, yes.
Yeah. Okay. So I'll be talking on ectopic pregnancy, its identification, laparoscopically, its management, and it's a video compilation of all the ectopic pregnancies at various sites. Is the audio, can you hear the audio?
Yeah, all good. One.
Okay.
Nanika?
Is it better if I speak?
No. Sorry to interrupt, but then I think it's a recorded one, but we don't hear to your recorded audio. We can see the video, but we cannot hear to your recorded
Okay,
audio.
so I will stop the audio and I'll speak myself, right?
Yeah, that's fine.
Yeah. Okay. So here I'll be discussing about the common sites of ectopic pregnancy. We know that there is an interstitial site, there is an isthmic site, ampullary and fimbria in the tube, and then there is ovarian ectopic, scar ectopic, cervical ectopic, and abdominal pregnancies. So there's different percentages of all the presence of all the ectopic pregnancies at different sites. I'll be discussing the video presentation of all these ectopic pregnancies. So this is the first video where I will be demonstrating ectopic pregnancy in a ruptured, as a tubal ruptured ectopic pregnancy. So here you can see that there is gross hemoperitoneum, and then there is a tubal ectopic tissue in the ampullary region of the tube, and therefore it can be demonstrated by the diagrammatic representation at the corner. So as we suctioned out the contents, the blood content, we could identify the ruptured ectopic part of the tube on the right side, and the treatment remains salpingectomy for these patients. Once salpingectomy was done, the ovaries and the tube of the other side was examined, and they were found normal. These patients do conceive normally with a single tube also. And this is another video of an unruptured tubal ectopic pregnancy. And here I will be demonstrating the isthmic portion of the tube where the pregnancy was had developed. So this position is actually the unruptured, this position is actually the isthmic region of the tube, which can be demonstrated by the diagram on the side. Again, this is an unruptured ectopic pregnancy, and therefore there is no blood in the cavity. In these patients, salpingostomy can be done, and however, I prefer salpingectomy over salpingostomy. And it's a clear procedure. The tissue was very comfortably removed in an endo bag made from a glove and removed through the 10 mm port. This another video shows tubal abortion. Now, tubal abortions can be identified by seeing the clots and blood on the fimbrial end of the tube, and there might be presence of pregnancy tissue or the abortion tissue in the pelvis. So here on examination, we found that the entire tube was otherwise normal. It had edema, but it was not as dilated as in an ectopic pregnancy. However, in these cases also, there is a possibility of some redundant ectopic tissue within the tube, which might not have been aborted, and therefore we prefer to do salpingectomy in these cases. As the salpingectomy was done, the rest of the tube, the tube on the other side and the ovaries and the other pelvic organs were examined. These patients do get pregnancy in the subsequent cycles. And this is another interesting video of a tubal ectopic pregnancy in both the tubes simultaneously. So this usually is the condition when sometimes even spontaneous. This wasn't spontaneous case, although, however, there are situations where in IVF pregnancies, such situations are very commonly found. So here you can see that both the tubes are having an ectopic pregnancy simultaneously. The fun part was that this patient actually conceived spontaneously. So one side, on the right side, there was tubal, there was a rupture, and on the left side there was an impending rupture, and we could see large blood clots on both the sides. And as we try to assess the anatomy, remove all the clots, we were able to identify the rest of the anatomy of the pelvis. And here again, the treatment remains salpingectomy, and this patient had to be posted for IVF in the subsequent cycle for pregnancy later on. The tissue was again removed through an endobag made from a glove, which is a very comfortable way of removing tissues, smaller tissues. Now, this is a case of a chronic ectopic pregnancy or pregnancy of unknown origin, or the abdominal pregnancy. So, this patient had actually come with a beta HCG report of showing pregnancy, but there was no ultrasound evidence of pregnancy, intrauterine or extrauterine. So, we decided to take this patient for a diagnostic hysterolaparoscopy to understand where this pregnancy test is coming positive from. So, this is the hysteroscopic view of this patient, wherein we were able to see the ostia. The cavity looked clean and technically not pregnant. And an empty cavity was identified here. And as we went into with the laparoscope, we saw that there was some amount of hemoperitoneum. The tubes and ovaries grossly looked normal. The uterus looked non-pregnant. And as we were exploring the pelvis, we found that there was some tissue which was just present below the right tube. And this greenish and fluffy tissue was actually the pregnancy tissue which was stuck to the uterosacral on the right side. And when we had sent this tissue for its pathological examination, it confirmed the presence of pregnancy. So we removed this tissue, we cleaned the entire pelvis, and her beta HCG started to fall in the subsequent examinations. So these are usually the cases of pregnancy of unknown origin or an abdominal pregnancy. Now, this was another interesting case of an ovarian ectopic pregnancy. Here, this patient, there was a lot of blood clots in the cavity, and as we removed the blood clots, we were trying to find the pathology because the tube on the right and the left side was looking grossly normal. There was a large blood clot which was actually covering the right ovary, but as we removed the clot, we found the rest of the entire pelvis to be absolutely normal. There was no other site of bleeding or a pregnancy. But as we moved the ovaries, as we uplifted the ovaries, we saw a small punctum and a punctum on the ovary. And this kind of a picture sometimes is seen in ruptured corpus luteum cyst also. But since this patient had a beta HCG positive, therefore we decided to take some tissue out of it. We irrigated this punctum and we took out some tissue. And that tissue, once it was sent for histopathology, confirmed pregnancy tissue also. So this is how we were able. So ovarian ectopic pregnancy is usually in certain cases is actually confirmed with a histopathological examination only. Rest everything was fine. We also did a chromoperturbation test for the tubes, and everything else looked perfect. Yeah. Now, this is a case of a scar ectopic pregnancy. Now, this patient is actually having a bicornuate uterus, and the pregnancy was there on the right horn. And the left horn, you can actually see a small left horn here. So this patient had come to us from referred from somewhere because she had undergone, she was diagnosed as scar ectopic, and they found that they tried to suction the scar ectopic tissue. And in spite of their suction evacuation, there was some tissue left in this patient. This patient was bleeding significantly post suction and evacuation. So as we removed the UV fold, we saw a big area of, a area where the tissue was very less, and there was a bulge noted. Again, after identifying the bulge, we separated the rest of the bladder below and exposed that entire area to a larger extent, because we needed some more space to suture later on. So this was the bulge we found, and we used vasopressin to prevent any extra bleeding. And just a single stroke, with just a single shot of harmonic, the rent, actually the previous scar rent, gave away, and inside we were able to find the clots. Now these clots were suctioned out, and the cavity, the rent was thoroughly cleaned. And after cleaning, we decided to suture it laparoscopically. So these patients where scar ectopic was seen, they are very comfortably managed on laparoscopic management. However, in this patient, she was not technically a complete excision through laparoscopy, because she had already undergone a suction and evacuation vaginally. So here the rent of the rent of the uterus was sutured with Vicryl number 1 in 2 layers. Complete hemostasis was achieved, and this was the final view of the picture. Then there is a corneal ectopic or interstitial pregnancies. Now these corneal or interstitial pregnancies, basically Thielen give two different theoretical explanation to corneal and ectopic and interstitial ectopic. And they said the corneal ectopic pregnancy is the one that is located in the upper and lateral part of the uterine cavity. And the interstitial pregnancy is technically implantation that is occurring in the most proximal part of the fallopian tube that is surrounded by the myometrium. So corneal ectopic is technically a tubal pregnancy, whereas interstitial pregnancy is technically a uterine pregnancy. So here I will be showing you the difference. So here, in this case, you can see this was an interstitial ectopic pregnancy, because there was some redundant tissue towards the uterus left, and the maximum bulge was in the fallopian tube. Therefore, after the theoretical definition, we did categorize it as an interstitial ectopic pregnancy. So we opened the tube, we suctioned out the products of conception. And after doing that, we also did the salpingectomy for this patient. And then the corneal end was then cautered with bipolar. These patients, sometimes they do require suturing at this corneal end. However, this patient, since it was technically an interstitial pregnancy, there was no obvious involvement of the myometrium, and therefore cautery was enough. Now, this is actually the case of a corneal ectopic pregnancy, where you can see this ridge in the middle, and there's this huge bulge. The reason why it is becoming this huge bulge is because there is myometrium also around it, right? So therefore, this pregnancy became this big. And here, this ridge is actually the one which shows that there is a possibility that it's more on the corneal, as a corneal ectopic, than actually in the tube. And this is how it was sutured. Resection was done. This is a wedge resection done for these corneal ectopic pregnancy, and suturing was taken because, yes, a part of myometrium is also removed while removing this ectopic tissue. So thank you very much. And with this, I would like all of you to please have Dr. Bhaskar Pal's support for the next presidential elections. Thank you.
Thank you very much, Ananika. It was a nice talk. It's a very crisp topic, a topic which is very close to my heart because I keep presenting quite often. Only a couple of lines about it. When you have a very small ovarian ectopic, you can go for a cystectomy, but you have a larger one. I think an ovariotomy should be done. Is something which I would like to add upon that.
Yes.
Very nice thing about the corneal interstitial. We keep misusing these two words, very common. But good, you brought it out, and it was a nice thing. On the whole, very nice presentation and good collection of your videos also.
Thank you.
It was a short of time. Thank you very much, Anika, for this. May I invite the next speaker, Dr. Atishay Jain. Dr. Atishay Jain, welcome. Pashal, may I have the CV, please?
Yes. So
He
Dr.
is
Atishay Jain speaks on the art of retroperitoneal dissection and anatomy of retroperitoneum. He's a consultant laparoscopic surgeon and fertility specialist, Asian Institute of Infertility Management, Indore. Dr. Atishay, the floor is yours.
Thank you, ma'am. I would like to thank Bhaskar sir for having me here. And so today I'll be talking about the art of retroperitoneal dissection and the anatomy of the retroperitoneum. So retroperitoneum is a beautiful space, as we all know it, and it consists of all the vital organs like the vessels and the nerves and the ureter. When you don't know the anatomy, you don't know how beautiful it is. But when you know the anatomy, you actually know how good it is. So the cases can be simple or complex, but the pelvic vascular anatomy is relatively constant and it has a very predictive retroperitoneal course. So when you want to enter the retroperitoneum, there are basically three approaches: the lateral, the posterior, the medial, and the anterior approach. So the retroperitoneum is divided into lateral spaces and the medial spaces. The lateral are the pararectal and the paravesical spaces, while the medial spaces are the retropubic, the vesicovaginal, rectovaginal, and the retrorectal spaces. So the most commonly used approach or the lateral approach. In this approach, we enter the retroperitoneum by marking an imaginary triangle between the round ligament, the IP ligament, and the shadow of the external iliac. And this is how we do it. And in this approach, we are marking the imaginary triangle, and we first start. We can either start from the top or below, and then we go layer by layer. We cut the Firstly, we cut the peritoneum, and I'm using the ultrasonic scalpel, the harmonic over here, and we can either cut the round ligament or we can leave it. It depends on which surgery we are doing. In this case, we were doing a conservative surgery, so we just let the round ligament be, and we need to go layer by layer, and we don't need to fight with the tissues. We need to just separate them and cut them when you find some difficulty. And here, the first structure that we should see is the ureter, and we can identify the ureter with its peculiar the vascularity and the peristalsis. Lateral to the ureter, you will see the internal iliac vessel, and the internal iliac vessel gives out the uterine, which is the first branch bit, which crosses from the lateral to the medial side, and it has a peculiar bluish hue, as you can see. And this is on when we start dissecting laterally, we see the obturator umbilical, which is the continuation of the internal iliac. And on the lateral side, we will go and we will see the vessels and obturator nerve. This is how we can see the obturator vessel. The nerve is now clear, and the artery is clear, and the vein is below it. So in this situation, we need to be very careful, as you know, a lot of vital structures lying there. A little bit amount of bleeding might damage might lead to a lot of bleeding. The corona mortis also lies here, and laterally, as you can see, there are external iliac vessels, the artery and the vein. And here we have a bird's eye view of it: the ureter, the artery, and the external iliac vein, the external iliac artery, internal iliac, the uterine, and the obturator. So there are some useful tips to go into this space. So firstly is mapping the imaginary triangle and then opening the retroperitoneum. After lifting the peritoneum, you need to have, you can do it with either one helper hand or just your left instrument. And the gas does a lot of work for you. So let the gas show its effect. And whenever in doubt, you should do blunt dissection rather than just cutting the structures, because you might just cut some important vascular structure. And always be parallel to the tubular structures like the ureter. So firstly identify the ureter and then go lateral to it, and always keep the ureter medially. Now, the posterior or the medial approach, this approach is used quite a lot with when you are performing cases of endometriosis. And in this approach, we enter the retroperitoneum medial to the ovary and the IP ligament. So, this is a case without endometriosis. So, here you can see the shadow of the ureter, and we start from the pelvic brim and start going downwards towards the uterosacrus. And when you keep going down, you should always keep the ureter under vision. And this video is just to show you the anatomy, and then I'll show you another video of the medial approach or the endometriotic approach. So you can see the ureter, and above it you can see the shadow of the uterine crossing the ureter. So here is a case of deep infiltrating endometriosis. Here we start from the pelvic brim, the unaffected or the virgin area, and then we start with the visualizing the ureter. So ureter can be confirmed as a peristalsis and its vascularity, and keep going down, and always keep the ureter under vision and then cut it. And sometimes you can just use the ureter to open the spaces. And once the ureter enters the tunnel, then you can start going medially towards the uterosacral and the rectovaginal tissues, the rectovaginal area. So here, as you can see, the ureter is being mapped, and we're going down towards the tunnel of the ureter, and then we'll turn around medially, and then we can start on the lateral side of the rectum in the pararectal spaces. Here we can see the inferior hypogastric nerve in most of the cases, but don't try too hard to look for it because you might just end up damaging it. And here the POD was obliterated, so we are just creating the rectovaginal space also in the same case. So you can just visualize the rectovaginal space also in the same case. So as you can see very clearly, we are using the ultrasonic energy as well as the bowel grasper to create the space. We are not just cutting without seeing, but we always visualize the rectum and the rectal fat and always remain above the fat, and don't go way too deep in the fat because you might just end up reaching the rectum and cutting it down. So always take a note of the fat and then cut it before just cutting it without seeing it. And here, as you can see, we are just about to open the rectovaginal space, and we are just keeping the fat below and cutting right above it. And in this case, in such cases, you can take help of the rectal probe, and also in some cases where that's not well demarcated, you can use a gauze in the this thing called phonics also. So as you can see now, the rectovaginal space is being created, which is usually obliterated due to the involvement of the rectovaginal nodule. And the rectovaginal nodule you can either cut it towards the vagina or towards the rectum, and then shave the rectum as if it is superficial, or plan another management for it depending on the depth. Now, useful tips are the bowel mobilization on the left side by removing the congenital adhesions, mapping the ureter and the IP ligament. Open the retroperitoneal space in between the ureter and the IP ligament, and dissect parallel to the ureter, keeping an eye on it. Now, the anterior approach is one approach which we don't commonly use. So I'll just show you the two spaces, the vesicovaginal spaces and the space of Ritzius, the retropubic space. So vesicovaginal space, I think we all are doing. This is the case of previous LSCS. So we just started from the lateral window approach, and just seeing the fat and keeping the fat above and cutting below it. So this is the vesicovaginal space that which we are developing, and this is the space of Regius. So this was an interesting case, as you know, this was diagnosed as a case of subserosal fibroid on the anterior part of the uterus and near the cervix. But this was diagnosed on the MRI somewhere outside, and this patient came for a myomectomy. But it ended up being a case of bladder endometriosis, and it was a bladder nodule, which I'll be showing you. So in this case, and when you're going for the dissection of the space of Ritzius, you should always fill up the bladder, see the boundaries of the bladder, and just cut above it. And the space of Ritzius is opened up in most commonly in the cases of stress urinary or incontinence when you're going for a birth, and whenever you need to dissect a nodule on the bladder or to reduce the pressure over it, the tension-free anastomosis, or a case of fistulas involving the bladder, where reimplantation is required. And here we just see where the boundaries of the bladder and cut above it. Now the spaces are being created, and we've already filled up the bladder, so we know we are safe, and we are cutting above it, and we are cutting only the peritoneum and the fatty tissues. And here the fat should go towards the bladder, and as you can see, the bladder is going down, and the space is being created. Now we are not going too deep because we did not want to go for a birch or anything. This was just a case of a bladder nodule where we excised the nodule and we sutured it, and it was in the dome, so we did not need any stenting or anything. So you can now see the bladder endometriosis here. Here it is. So useful tips for the anterior approach is it is a retrograde dissection. You identify the medial umbilical ligament first, and then keep going down. And first, the artery is encountered, and not the is not the uterine artery. And the eye see what the mind knows. Thanks a lot, and thank you, Bhaskar sir.
Thank you very much, Atishay. That is a very nice talk. It's always an anime. I really liked your first slide, no, where you showed how it would be without knowing the anatomy and after knowing the anatomy. Very nice talk, very crisp
Yes.
talk. Again, let me request all the fellow speakers to please stick on to the time, please. And may I welcome the next speaker. Yeah, Poshali? Yeah. Thank you, Atishay. Thank you very much for that.
Thank you. Thank you.
So our next speaker is Dr. Rohan Krishna Kumar. He's an MS OB-GYN fellow. He has a fellowship in gynae oncology from Ahmedabad.
Can
And
start sharing my screen.
okay,
Can skip the
sure.
intro.
And
Okay, no
right. So
problem.
he speaks on new developments in endoscopy.
Yeah, the name speaks for
So,
itself. Dr. Rohan Krishna Kumar. Welcome.
thank you, Subhash sir, so much. Thank you, Bhaskar sir, and entire team for having me and giving me this chance. So today I'm here. I saw that a lot of people are presenting on endometriosis. So I decided to present on
King
something
RK?
new,
Yeah.
which is just role of ICG and HTRS and how we can use innovative new technology for our health. So without any delay, ICG is long developed back in by Kodak during World War II to aid infrared photography and for spying, and it's easily water soluble. We all know that it's easily excited by light between 700 to 800 nanometers, and this is used with the ICG camera by switching to the near infrared imaging to see the green color of the dye. So it's very easy to store, very easy to prepare. Prepared in distilled water, it can be stored outside for 6 to 10 hours as it becomes unstable on too much exposure to light, or can be stored at 2 to 8 degrees for some time. It's approved by FDA since a long time and is being used for interventional surgery since 2000. We all know I've presented this a lot earlier because it's very much useful nowadays in sentinel lymph node mapping for vascular architecture concern. Plus, with the increasing number of resection anastomosis that we are doing for endometriosis, this also becomes very valuable over there. So I was shocked to know, apart from the malignant indications, there are so many non-malignant indications like checking the tubal perforation, the urethral perfusion, the perfusion after the uterine transplant, urethral visualization, and now also in endometriosis. So after resecting many nodules, you can check for hypoperfusion in endometriosis. You can check to prevent fistulas and ischemia-related complications, and also helps to assess the vascularity of bowel as well as the ureter. So this is a video showing its use in endometriosis. We had used it IV, and you can see it's a case of grade 4. I mean, yes, we would all know that people who are trained to do endometriosis surgery can negotiate through this, but we were trying out the ICG system. And once we injected, you can see when we injected the ICG, the dye has spread and we can easily locate the ureters without much trouble. So even without, just predicting where it is, we can see where the ureter is and carefully go ahead and dissect it, preventing any undue injury or devascularization of the ureter. Going further, this is after a case of bowel resection. I'll skip for being on time. This is after the colorectal anastomosis. You can turn on the ICG so that you can see any avascular areas. Also, while doing colonoscopy, this is the resection line from inside. You can see the ICG very clearly, and if required, you can take stitch if there's any avascular area. So this is how it helps there. Now, this is a very nice video where I have compared the ICG available from all the systems. Not many people must have tried all of them. The first one is the SQLab, the second one is the Olympic, Striker, and Stores 2D with the older version, which does not has overlay. So overlay means you do not have to switch to the dark mode. You do not have to switch the light to the infrared camera. Like in the SQLab system, you can see you can't see the other tissues. Whereas in the Olympus and Striker, you can make out the difference in the other tissues very clearly to identify. You don't have to switch every time you want to see the ICG node. You can see it while you're doing the surgery. So that's the advantage of the newer systems. And you can see all of them have a very good clarity, and many imaging systems are coming up with these type of systems to improve the surgery. And we should be able to use this in order to avoid inadvertent complications of lymphadenectomy like nerve injuries as well as undue lymphedemas. So going further ahead, this is something new. This is the Rubina 4K 3D, which has so many modes that is difficult to express. Here you can see the retroperitoneum is already open, and we can very clearly see the green stains. That is the ICG, and this has overlay. So you don't have to switch. That's the uterine artery there, opening the pararectal and the paravesical spaces. I'll just fast forward a bit so that I don't repeat the things. So this is just the retroperitoneal anatomy. You can see once you identify the node, which is usually mostly over the external iliac vessel on 60% of the occasion. Now this you can use to see, you see the color change from green, now it's become gray. And the more the dye concentrated in the center, the more it takes up this white color. So that's easier to identify whether exactly you're tracing ICG and it's not an artifact. Plus here you can further see there is these oranges color appearance which also indicate where the dye is concentrated more. So these modes are available in the new source system, which are all very important to know that you're not missing out the area where the dye is the maximum, because that's the first place the tumor would have spread and you want to biopsy these areas. So apart from that, overlay and these other things are also available on that. Going ahead with other imaging systems that are now available. Now, this is a new camera that we very recently tried for our surprise. It was really good. You can see there's something called as a fat enhancing mode, which also works on infrared technology. And you can see it is reflecting more light on the fat. Now, once the retroperitoneum is opened, you can see all the fat is looking more yellow compared to the other structures. And so as the fat on the ureter, I hope I'm audible because I'm just going on talking and it's been a long time since I've been on Zoom. So this is how dissecting on the uh, ureter is. You can see the yellowishness on the ureter indicates that the fascia is still there, and hence you can preserve that fascia very easily. So these may not be required for people who are regularly doing, or people may say this is not required, but for newcomers to identify this, these camera systems and imaging systems help a lot. Going further ahead, if you want to start off doing difficult surgeries, you might use these LED stents in the ureter. You can go ahead, stent the ureters this way, and further uh, put it through past these LED stents. And I'll just fast forward to save time. Yeah, you can see this is how the stents work. And intra-op, you can see these beautiful signals that you get while operating. Many people won't stent it. Even we don't stent it. This was for trial, but it's very useful for somebody who wants to start off difficult surgery and is scared of retroperitoneal anatomy. So these are simple investments that you can make, which will help make your surgery safer. Further, my next area is on newer hysteroscopes and newer technologies. In that, we saw a brilliant talk by Amok where he described about scissors and resectoscopy for RPOC. So here, unfortunately, for the time, I thought I shouldn't include the RPOC videos. I've not included. So we all know hysteroscopy. We all moved from DNC to hysteroscopy to prevent uterine synecdoche, that is adhesions, and uterus hysteroscopes became miniature and miniature so that we can use them more easily without dilatation, without losing the virgin view. So Asherman's, we found that almost 13% patients undergoing DNC for the first trimester pregnancies are prone to it. Late pregnancies, incidence is almost 30 to 40%. In fact, hysteroscopy, as I said, was introduced to widely prevent and treat this, but unfortunately, that's not happening. We still see Asherman's after hysteroscopic procedures. Surprisingly, the literature shows that almost 31% of women undergoing myoma resection with a resectoscope may have Asherman's. Plus, for large septums, it is almost as high as 46%. So we know iatrogenically we are still creating Hmns which we actually set out to prevent. So coming to these newer oscillators, there are two metal hollows that fit into each other. The inner tube rotates. It's driven through mechanical energy activated by a foot pedal. The tissues are sucked, so the field is always clear. Uh, it also minimizes complications because you can enter directly with that. You don't have to change your instrument, dilate the uterus, keeping the field clear. So the field is always nice. You don't have to enter two times. You don't have to dilate. Simultaneously cutting as well as evacuation prevents any accumulation of tissues that are there. And due to the integrated designs, there's hardly any failure. There's reduced pain because you don't have to go in and out with the instrument again and again, again and again, and you don't have to evacuate those things, reducing the chances of perforations further. So this is our experience. This data was till Jan. We started using this from I think October or somewhere around end of September last year, and this is still Jan. It was somewhere around 33, 35 cases. Now the numbers have increased, and we are increasingly finding it more and more effective. Now this you won't believe. This is a infertile patient wanting to undergo IVF. She had a submucous fibroid, so we decided why not try with this. And this was done in the office. This was done without anesthesia. You saw we entered directly with that. We didn't have to use a diagnostic scope to first see our ultrasound scan was enough. We could directly, this is a 6.5 instrument. You can, with the scope as well as the morcellator, the insert is 3 mm. You also get 3 mm graspers and scissors in case you want to use it. But you can directly enter through this without dilating, just bloodless. And you can see it's cutting through the myoma like a piece of cake. There's hardly any tissue. Usually, when we use resectoscope, we see those big bubbles. We see tissue lying around the uterus, obstructing our view, and then we have to stop, remove everything, clear the field, and then go ahead. So sometimes with the suction move, it may show some bleeding, but it easily clears off. There you can see this procedure is almost completed in a span of 4 to 5 minutes in office, that too without anesthesia. So the patient just walk back home. So that's how easy it is to use all this. Plus, this is a very interesting case. She had undergone 2 abortions, 41-year-old. She was shown to have a septate uterus. So we decided to go directly with a hysteroscope instead of giving her any mifepristone, misoprostol. We directly went in to diagnose what the pathology is. So here you can see there is a missed abortion, the GSAC in the right horn. You could see a septum in the left horn. If you just missed it, I'll take it back. You can just see in the starting. Yeah, yeah, there is the left horn here, and then when we go towards the right, you can see a sac there. So these things are easily going to be missed out when you do directly a DNC because you're going to dilate. You don't know which cavity you're going to approach. You're going to damage the entire endometrium while doing your DNC. So with this, we morcellated with this tissue retrieval system the entire GSAC. You can see clearly. I'll just show you once the procedure is done. This will, of course, bleed because the contents of the sac will also keep coming out. You can see without touching any other part of the endometrium. So we are doing this routinely now for many of the RPOCs, even some difficult embryo transfers where we can't negotiate. We are using this HTRS to actually if there's cervical stenosis, we're actually correcting it with this instead of going in with the dilator. So you can see we have not touched anywhere else in the endometrium, just dealt with the difficult part. And in the second sitting, planned a hysteroscopic septal resection. So that's how technology is useful in preventing more and more complications in solving it ourselves better. There are many studies here showing that morcellators are better compared to electrical resections for polyps as well as myomas. They've analyzed patients and found more number of live birth rates in which morcellators have used compared to resectoscope. This is probably because of the less damage to the endometrium. Al-Healy also postulated that he reported lack of intrauterine adhesions because of less mechanical damage, because of less use of curettage and electrical energy. To take home, it's less time consuming, minimal damage, comparable to resectoscope and cold scissors in treatments of myomas and polyps. Better than blind curettage for RPOCs, easy handling, less learning curve. Yeah, of course, it's expensive now, but only when you invest in technology do you do better. Similarly with the ICG system, so I hope I have been able to convey a good message to all the newcomers and everybody wanting to learn that always be open to adopt new technology, unlearn to learn new things and keep evolving like all the other speakers would tell you. With this, I would like to end. Thank you very much. Thank you, Bhaskar Pal, sir. And it's a pleasure. We all know that you're an excellent leader. When you were the IAG president, we had an opportunity to interact closely. Thank you very much, sir.
Thank you very much, King RK, Don RK. It was a very nice talk. Like as you
Something different, something.
yeah.
something.
Innovation is the future delivered, bro. So it is a very nice one. It's a very good thing. You've given us a lot of idea about the things that have come down, how to utilize it for the proper you know for the proper way, so that our understanding of the subject and for the patient altogether goes down very well. Thank you very much, RK,
Thank
for the
you. Thank
wonderful
you.
talk. Okay, thank you. Thanks, Pashali.
So our next speaker tonight is Dr. Santwan Mehta, who speaks on interstitial tubal ectopic pregnancy, a novel method of treatment. He's a fellow of minimal access surgery and reproductive medicine, and he's a consultant gynae lab surgeon at Mayflower Hospitals, Ahmedabad. So Dr. Santwan, the floor is yours.
Thank you
Welcome,
very much,
Santwan.
ma'am.
Welcome.
Thank you, Subhash bhai. Can you please allow? Yes, I got it. Okay, so I'm sharing my screen. So it's indeed a great honor for me to join this esteemed webinar. Thank you very much, Dr. Bhaskar Palsar and Dr. Paushali, to coordinate the things and giving me this opportunity. So today I'm going to discuss a very uh, common topic, the ectopic pregnancy, but a little different, the interstitial tubal ectopic pregnancy. So like we do know that tubal ectopic pregnancy are very common nowadays because of the increased ART. And we do come across so many cases like this. Ectopic pregnancy itself is a very debatable issue, starting from the diagnosis and up to the management, like whether we should go for a more conservative approach of salpingostomy or we should go for a radical approach of the salpingectomy. But today I'm going to restrict my talk mostly for the ruptured ectopic pregnancy where the patient comes with a severe abdominal pain. She is hemodynamically unstable and having a lot of hemoperitoneum. So in such cases, we are always going to go for the salpingectomy only. Now, as you can see in this video that now gone are the days when for the ectopic pregnancy, we have to sort for the laparotomy. Even if there is a huge amount of hemoperitoneum with a good anesthetic team with us and a good blood bank availability, we can resuscitate the patient, go into the go into the abdomen via laparoscopy, and with this good hemostatic vessel sealer machines available, we can just target the ectopic area, ruptured area, control the hemostasis, and just beautifully come out of the surgery. And patient usually does fantastically well within few hours only. But the things become little bit difficult when the ectopic pregnancy is more proximal, as in this case, the tubal ectopic mass is more near to the cornual pregnancy. So this is the tubal interstitial ectopic pregnancy. Dr. Nainika has also showed some of the good videos about the ectopic. Now the problem with this kind of ectopic pregnancy is it's highly vascular because this kind of ectopic mass uh, does get dual blood supply, one from the uterus, other from the ovarian vessels. So no matter how hard you try to cauterize that, they will keep on bleeding. In the past, many of the surgeons have abandoned the laparoscopy for such cases, gone for the laparotomy, and sometimes they have to sort the hysterectomy also because this cases has a very high mortality rate. So normal routine criteria for the as I told you, the proximal interstitium is the proximal part of the tube which lies within the muscle wall, and because of its dual blood supply, the maternal mortality rate is as high as 2 to 3%. Usual way of dealing with such ectopic pregnancy is a wage resection. So like it's a technically little bit complicated. You have to put a vasopressin, apply the monopolar diathermy, get out the wage, and then do the corner resection and the suturing. So it's technically demanding, as well as there are, as this case in studies shows that there are many cases of the uterine rupture in the next pregnancy. So today I'm going to show a very simpler method to deal such cases. We had such case, a patient who was 34-year-old and came to the emergency department with severe abdominal pain and unconsciousness. Her UPT was positive and she was having tachycardia and hypotension. Sonography showed massive hemoperitoneum with a left ectopic mass on the left adnexum. So we resuscitated the patient, went inside. Now again, sonography in such cases is also very challenging. Like you have to be very careful before deciding, before labeling it as an interstitial ectopic pregnancy. So we went ahead, tried to check for the right side normal tube and the adnexa, and then we saw that the tubal ectopic mass on the left side, and so yes, it was an interstitial ectopic pregnancy. So obviously, it's going to have. I'm sorry. Okay, so here what we are trying to do is like this ectopic mass, if we find out some endo loop or something like that, which kind of prevents its blood supply from the uterus, so it will be easier to achieve the hemostasis, and then we can have the easily removal of this mass. So to apply the proper endo loop, I'm just removing the excess tubal part. Then now I have introduced the endo loop, which is a chromic cadet loop. This is the same loop which surgeons are using for the appendectomy. Now applying the loop at the base of the ectopic mass in order to achieve the hemostasis to cut off its blood supply from the uterus. And for the safety purpose, I'll also apply a second loop also, so that slowly gradually you will appreciate that the bleeding has now gradually reduced. It's almost bloodless now, and now once it has cut off its blood supply, I'm removing the ectopic mass very easily without any bleeding. So you can appreciate that it's a very simple technique which serves a good purpose, easy to learn, and it does not take that much of time also. So there is hardly any blood loss, and again, it will have a magical effect on the patient's recovery. This is a study which was done by the Moon et al. They studied 24 patients with this endoloop, and they have reported that it is a simple, safe, and effective, nearly bloodless surgery. And even there are no cases of uterine ruptures are also seen in subsequent 11 patients with the term pregnancy. So my take-home message is interstitial ectopic pregnancy is not that uncommon. You may find it at times. It is indeed difficult to diagnose sonographically, so you don't have to be only ectopic conscious, but on interstitial ectopic conscious also. But because sometimes you may find surprises while handling these cases. It is a surgical challenge, but with proper training and this endoloop. So keep an endoloop always there in your OT to take care of such cases. Thank you very much.
Thank you very much, Santwan. It was a crisp talk and a lot of positive advice. Now, any questions from the audience on this? Do we have? Right. No, no question. Okay. Thank you very much, Santwan, for that.
Thank you. Thank you very much.
You finished well before time. Thank you very much, Santwan. Right, Vaishali.
So our next speaker is Dr. Smeet Patel, who speaks on fantastic tissues and where to find them, a surgeon's perspective on endometriosis tissues across the pelvis. So Dr. Smeet is the director of Mayflower Women's Hospital, Center of Excellence in Endometriosis and Gynae-Oncology. We welcome you, Dr. Smeet, and please go ahead with your presentation.
After a big dawn from the other side of Ahmedabad, we have the big dawn from the other side of Ahmedabad now, right? Tamil, welcome, Smith bhai.
Sir, namaste. Namaste, Subhash bhai. Poshali ma'am, thank you very much for the kind introduction. First of all, I would like to congratulate Bhaskar Pal sir and thank you very much for this opportunity to the entire team. I'll just share my screen. So we dive right into the deep forest of endometriosis. And this forest has some mysterious, dangerous, but very interesting pathologies. So I like to call them the fantastic tissues. Over the next few minutes, we'll uncover and understand this mysteries of the forest. And I have titled this talk as the fantastic tissue and where to find them. These are the different fantastic tissues, and we have tried to identify types of endometrial daily life. So let's dive in. The hood. It is heavily angiogenetic, bleeds upon touch, and mostly it is superficial in nature. You can see the red angiogenetic part. So endometriosis is always a very vascular disease. It is always a bloody surgery, and the angiogenetic part makes it so. So all the angiogenetic nature of the endometriosis you can find almost in all the cases of endometriosis. Now we have cherries and chalice. These are fluid-filled cysts, often concealed and of varying content. So this is a one example where the cherries and chalice kind of tissue is found in the ovary. We are doing the cystectomy here, and you can see that all this there is a mild covering over it with a liquidary endometrioma inside it. Next, we have plucky peaches. These are cystic fibrotic tissues. There are no clear margins, and it is almost angles and organs. So I'll give you an example in the uterus. You can see we are doing an adenomyomectomy. We are doing the hood technique, and in so you can see this part of the cystic collection, which is having a cyst, a volcanic kind of activity, which has unclear margins, and it's like a fibrotic mass inside. Next, we have bundle of Woos. These are fibrotic tissues, thick and dense mass. We always see them as the white lesion of endometriosis. These are actual endometriotic tissues which are fibrous on the tissues which these are the tissues on which the fibrotic action of the body has taken care of, but they are active glandular part. The next one is poison pill. So this happens because of prolonged medical management in case of endometriosis. To describe this tissue, we'll have to understand that something like rubbery consistency, we cannot pull that. Also, we cannot cut them with a proper direction. So, as we all know, the growth of endometriosis, there is an ectopic endometrial gland. It grows over the influence of hormones. There is shedding. It has nowhere else to grow, so there is going to be fibrosis. In the next cycle, again, so growth, shedding, and fibrosis. So there is going to be a layer by layer approach. Endometriosis will always grow on a parenchymal tissue, which is on layer by layer basis. But in case of medical management, what happens is there is a shrinkage of tissue. There is compression like a sponge ball, and that is how the reduction in size of the nodule is there, but it occurs for only 6 months or so max. After that, the tissue is going to grow in a very rapid phase in an unorganized form, and hence we find this kind of tissue. So the tissue is no longer spongy and in layer by layer fashion, it is always in a different kind of consistency, which is very like rubbery, dense, rubbery. We cannot pull it, there is no elasticity in that tissue. The next is the resurrected one. These are the active glandular tissue and they are flimsy to touch. They are very fragile in nature. So most of the times we always find them on the posterior aspect of the uterus. So let us understand the first image of an endometriosis. There is uterus, bilateral kissing ovaries, the rectum is there, there's frozen pelvis. We'll always find this active glandular tissue on the posterior aspect of the uterus, and we theorize that it has come from the inside of the uterus, adenomyosis, and then there is the whole tissue which is surrounding the whole posterior aspect of the uterus. Next is the flary-felines. I also like to call them flary-felines. These are the post-surgical tissues and intense plaque formation is there. So if there is a previous surgery done in case of endometriosis, not a proper surgery, there was not a complete removal of nodules, there is recurrence of endometriosis, and this recurrence is in a very unorganized, very bad form. It is very invasive in nature and it grows over the previous surgery. So there is no proper, we can say that इसका अब कोई ईमान धर्म नहीं है. Next, we have swarm of sorrows, the infective endometriotic tissues. So how this is formed? Let us assume that there are multiple ovum pickups being done in case of a patient who has endometriosis, who has a rectovaginal plaque but not operated and directly went for an IVF. So what happens from the vagina? The needle pierces from the vagina into the rectum and into the ovary, into a closed compartment. So flora of the vagina, flora of the rectum, flora of the POD, and then into the ovary in a closed compartment, and multiple such pickups, and in multiple cycles this happens. Actually, we are inviting infection. So basically, we are carrying infection from right to the tip of the needle and directly into the ovaries. Such kind of tissues are the worst to take care of, and mostly in such kind of tissues we will have to do endoforectomy. So this I feel is the worst type of tissue texture. So often this also, so let us assume we have 8 different types of tissue taxonomy. This tissue taxonomy can often have in multiple permutations and combinations. We can have one, two, three, four, or sometimes we can have all the tissue types together in just one patient. So if you go for a permutation combination, we'll have at least 256 different types of tissue taxonomy. Depends on the patient. Every patient of endometriosis is different. That's it. We also publish this in our newsletter on endometriosis weekly. And any questions, I'll be happy to answer them.
Subhash sir. Thank you, Dr. Smith. I think Dr. Subhash sir is a little bit busy. It was an excellent presentation. If there, no, Subhash sir is here.
No, I was here. Right, Smith bhai.
Yes,
It
sir.
was very crisp talk again. But again, no, could you please tell us a couple of lines, about, there have been two conflicting views about peritoneectomy or else, the butterfly technique. Some of them say for infertility people, for infertility, once you remove the peritoneum, is it going to help? And the other school of thought says that if you remove the peritoneum, then anyway it's going to regenerate in 24 hours to 48 hours, so there's not an issue about that. So what's your take, on this? Because sometimes it is quite controversial, about the removal of peritoneum. So your take on it.
Sir, if the peritoneum is involved with endometriosis, to decrease the recurrence chances and to not have the patient a secondary growth of endometriosis, we always go for a peritonectomy. So the Mayflower butterfly peritonectomy, we remove the upper wings of the butterfly, which are the ovarian behind the ovaries. The lower wings of the butterfly, which are the area between the ureters and the colon and the uterosacrals. The body of the butterfly, which is the uterus, cervix, vagina, and rectum. All right. So if we remove this, we are basically taking care of the entire plaque, even with the torus uterus involvement at the base of the uterus and rectum. So if we do a butterfly peritonectomy, we make sure that all the nodules are removed. So we are always in favor of removing the butterfly peritonectomy. And with the subsequent surgery, since it is just the peritoneum at most of the sites, the reperitoneation starts in 24 hours. So chances of any adhesion being formed is almost zero. We have been showing this many times that we have done a surgery. When we do a CS for the same patient, we almost see like a few flimsy adhesions or no adhesions at all.
Right. Smith, thank you very much. I also have been following your, my journey of endometriosis on YouTube quite a few times, So it's really very nice to learn new things, Thank you very much, Smith, for
Thank
the
you very much, sir.
talk. And I'm very happy that many of you youngsters did join today and share your thought process. Right.
Thank
Thanks.
you very much,
Thanks
sir.
a lot.
Thank you, Dr. Smith. So our next speaker is Dr. Surakshit Batina, who speaks on laparoscopic cervical encerclage in pregnancy. Dr. Surakshit is an FICRS scholar, USA. He has a fellowship from various institutions across the world and India, and he has performed the world's first laparoscopic management of uterine rupture. Welcome, Dr. Surakshit.
Thank you so much.
Yeah.
And
Welcome, Surakshit. And not just that, he is a part-time model also. Yeah, so welcome, Surakshit, and it's a pleasure always to hear to you. And I really follow a few of your videos, including the what Latika also presented, the neo-vision technique of yours. Right?
Perfect. Thank you so much, Subhash. Let me just go ahead and start my presentation. Okay. All right. All right. Is my screen visible?
Yes, Surakshit. Yes, please.
Perfect. All right. I'm gonna start the presentation. So thank you so much, Bhaskar sir, for giving me the opportunity to present here today. So my talk today is going to be on the laparoscopic pregnancy stitch. So Yeah, so the definition of this is the inability of the uterine cervix to retain a pregnancy in the second trimester in the absence of any clinical contractions, labor, or both. And this is a very painful condition for the patients. And I think the best way I have found to address this is by a cervical encirclage. The port placements are quite simple since I'm a contralateral surgeon. My ports are contralateral, and I think this surgery is also a contralateral surgery because when the uterus is so enlarged, right, it's very challenging to do this from an ipsilateral angle. And here is the procedure video. As you can see, we have a gravid 13-week uterus out here. The only problem what we have is we won't be able to use any kind of uterine manipulation. So we use the round ligament to give us all the traction we need. So we always have to go millimeter by millimeter, and we also have to make sure that we don't we have a complete head low. So one more thing what I understood is that whenever we do this procedure, whenever you're doing any thing on the left side, you try to get the table tilted towards the opposite side. So that way the uterus also moves along with it, and the gravity plays its bit, and then it will help you perform the procedure much more efficiently. So as you can see over here, we are going again millimeter by millimeter, just pushing the bladder down. Use the pneumoperitoneum to your advantage. So always in all the other procedures, we try to be a little bit more quicker, but here we have to make sure that we're going slow and step by step. And because if you go a little bit faster over here, you might end up having a lot of bleeding, right? So again, over here we make a window in the broad ligament. This is absolutely important because if you don't do this window, it's going to be very challenging for you to move the needles just medial to the uterine arteries. So then again, here we pass the muslin tape, and you can see over here the needle is moving just medial to the uterine arteries. And then we do the same thing on the other side. See, again, this window is going to be very useful for you to manipulate the needle. Okay, so again, as I said, gently pull through both the tips, and then we put a total of around 5 knots, and then we check it posteriorly to make sure that there is no bowel loop entangled in there. And then finally, this is also very important. We need to hitch this the muslin tape to the uterus. Because if you don't do the step, sometimes no, it can go and erode into the bladder, and that might create complications later. So we always perform the step. And finally, to close the UV fold, to close the UV fold, either you can go for a continuous suturing or you can do a single suture. We've done both. I'll be showing you that pretty soon. So this is how this stitch looks while you're doing the C-section. So many of them say if the stitch is not working, or if in case you need to remove it, you can do a colpotomy and remove it. I don't think that is possible because you can see the stitch is deeply buried inside. Even though this bit is supposed to be exposed, you can see it gets buried inside the uterus. So it will be, you will be unable to remove the stitch once it's placed. Right. And the best part about the stitch is, this one particular patient, we placed the stitch for her in her first pregnancy, and the second pregnancy, we didn't have to place the stitch at all. The same one we were able to retain, and then she was able to go through a second pregnancy with no problems at all. So definitely, once you place it, you don't have to place another stitch again. Again, when you compare it to laparoscopic and a vaginal stitch, I think there's absolutely no comparison. Many people say it's the same, but I don't think so. There is a chance of a failure for a vaginal cervical stitch, but when you look at a laparoscopic stitch, it's a way up, and then the chance of failure is very, very, very less. So again, some of the tips I can tell you is if in case the patient has a previous C-section, always use the lateral window technique. This is going to help you to avoid any kind of bleeding or issues while you're doing. Again, as I said, sometimes I also use a gauze. This will also help in terms of for the pushing the UV fold down. Again, if you have posterior additions like these flimsy additions, usually most of the time it's flimsy additions only. So you can definitely go dissect them off first before you go ahead and place the stitch. Because if you don't do this step, no, you're going to have some challenge in trying to place the stitch later. Right. Again, take your time in finding the window because it's very, very important, because sometimes you'll have bleeding. So since I did close to, I think, 48 cases right now, and then we did encounter some bleeding, so I will be showing you what happens whenever bleeding is there. So as you can see, we did have small bleeders in one of the cases like this. So you can just go ahead and bipolarize it. Nothing is going to happen, so you don't have to worry too much about it. Bipolarizing is not going to cause anything. Sometimes the bleeding is more severe, like in this case, you can see the bleeding is much more severe. So at which point you can go ahead and you can bipolarize it as well. But unfortunately, in this case, no, it did not stop. So we go ahead and we can also use a tamponade with a gauze piece, and then we also used a interseed. And then sometimes you'll have also these odd locations of where the bleeding is coming from. That also is not a problem. You can go ahead and you can bipolarize it. Shouldn't be an issue. And but if in case after you tried everything and still the bleeding still persists, you can go ahead and tie the uterine artery on one side. So we have done that for two patients so far, and both the patients had a normal break. I mean, she had a C-section at around 36 weeks and no problem at all. So sometimes, suturing is the king. So I think it's very, very important, because if in case you have these kinds of odd locations of where you have the bleeding, definitely you should be able to know suturing at these kinds of odd locations as well, so that it makes your job easier. Right. Again, sometimes you will have patients who have these uniconjugate horns, so the altered anatomy is also there for some patients. So at which point you need to know where the uterine artery is, and then accordingly take the stitch. So as you can see over here, for this patient, the uterine vasculature is completely changed. So you have to skeletonize the whole peritoneum, and then you have to plan the stitch. Again, for sometimes, when for this patient, we also had to go retroperitoneum and open up the sorry, to check where the ureter is going, because sometimes the ureter also is very close by. So then once you do that, you can go ahead and place a stitch. Again, when it comes to the way how we can close the UV fold, we can use intermittent suturing. We have used also a single stitch for some of the patients, and most of the time I found that it is the same. We also done intermittent, complete closure, but I found that just placing a single stitch is more than sufficient. It's pretty much the same during the C-section process. Make sure that you remove both the needles immediately. Sometimes, no, you might have placed the stitch, a little bit lower down. So in that situations, this definitely you have to go ahead and place it again. So you can, remove your previous knot, and then you can place another knot just above it. So it shouldn't really be a problem for you to remove the stitch once you placed it. So only thing is you have to do it immediately. Sometimes also you will have these kinds of odd complications, right? When you're trying to remove the needle out, and then it might just pop out. So I also found that once we have done the procedure, look at the uterus looks quite normal right now, but after a while, you see how congested it has become. This also has happened in a couple of cases, but it doesn't really matter, because it really didn't change or affect the outcome of the pregnancy. So I don't think it's something that we need to really be bothered too much about, if in case you find this kind of congestion. And if you ask me what is the perfect time to go ahead and do this procedure for a singleton, I think 14 to 16 weeks is the perfect time. Anything before that, what happens is the uterus is too deep in the pelvis and it will be difficult for you to manipulate. When it's around 14 to 16 weeks, no, the uterus is much higher up, and then posteriorly it will be much easier for you to suture. So again, you can see, when you're doing this case and you just fast forward it, you can see the slight movements of the, fetus inside the uterus. I just found it fascinating. I wanted to show you that bit. And this is another case. It was a very peculiar case. So we had a patient who had bulging membranes out of the cervix. So as you can see over here, we have placed the stitch for this particular patient anyway, because she said she see some way or the other. I told her about all the risks what are possible. I told her that the amniotic sac can break. But then again, no, you can see somehow after placing the stitch, no, there is this whole hourglass kind of appearance over here. You can see there is free fluid moving from within the two amniotic sacs. Surprisingly, this lady, she crossed 36 weeks with no problem, and 36 weeks this sac ruptured. So at that point we had to take her up for a C-section, and then it was absolutely fine. Again, post-operatively, it's quite simple. We don't give any IV, tocolytics. We only give nifedipine and duodolon and foot and elevation, and then we see the scan the next day, and we send her home the very next day. The good thing about a laparoscopic stitch is that the patient doesn't have to be lying flat on the bed all the time. She can go do her daily activities. There's no problem at all. And we have quite a good case series, and all of them have delivered with no problems at all. So thank you again, Bhaskar sir, for giving me this opportunity. And I would like to ask everyone to, please vote for sir, because he's a lovely. We had an opportunity for him being a president in IAG. It was fantastic. So I think definitely, Foxy, we should do the same. Thank you so much, sir, and thank you, Subhash sir, for giving the opportunity. And yeah, thank you.
Thank you very much, Surakshit. The talk was a very versatile talk, as a versatile person that you are. We all
Thank
know for your wide variety of presentations in this particular topic, and it was a very wonderful one. We learned a lot of things. Again, on a lighter note and on a very serious note, of course, as I told you, that this talk is as versatile that you are. Many of you wouldn't know that he is actually a women's health advocate. He's a TEDx speaker. He has his own sports, clothes apparel, and more importantly, he's a fitness freak. So all you guys who would like to be, on to follow him, his Instagram is Dr. Baby Maker. It's a very catchy name. And you can go and see all his videos, whichever is put over here. And also for any interactions, you can always contact him at Dr. underscore baby maker. Right?
Thank you.
Thank you
Thank
very
you
much,
so much.
Surakshit, for your wonderful talk.
Thank you
Thank
for
you.
the plug, Dr. Suresh. Thank you. Thank you so much.
Thank you, Dr. Surakshit. We now have our next speaker, Dr. Tarun Joseph, who speaks on cesarean scar defect. So, Dr. Tarun is a consultant, Joseph Hospitals.
Yeah. After two spectrums of Ahmedabad, we have two spectrums of Chennai right now. The area, the northern part and the southern part. Welcome, Dr. Tarun, for your wonderful.
Thank you, sir. Thank you for having us. I think we are not too far apart in Chennai. We are practically neighbors. First of all, thank you to Basketball, sir, for giving us this opportunity today. Just let me share my screen. Yeah. Sorry. Okay. First of all, I'd like to invite everybody for our conference in August of this year, the Asia Pacific Association of Gynec Endoscopy. Promise to show everything. I think it will definitely be a conference you could benefit from. So quickly running on to the presentation. So the lap management of long-term effects of the C-section. So, we are all suffering for the sins of our fathers. All the cesareans that they have done then are coming back now with cesarean scar defects. So the cesarean delivery is one of the most common surgeries, nearly 10 to 60%. One of the long-term complications that we have nowadays are the unhealed defect. It goes by a few names. There's seal, uterine niche, cesarean scar defect. But whatever it is, we are starting to see more and more of it. 60% of patients with the cesarean delivery develop a niche. 25% of them a large niche with residual myometrial thickness. 30 to 40% has asymptomatic. The definition has always been up for grabs. The European Society has come up with a European Niche Task Force, the definition of which has now been given as an initiation uterine myometrium of at least 2 millimeters at the site of the cesarean scar defect, which can be assessed by TVS. Now, to make a diagnosis, you need one primary or two secondary symptoms. The primary symptoms are postmenstrual spotting, pain during uterine bleeding, technical issues with catheter insertion during an embryo transfer, and secondary unexplained infertility combined with intrauterine fluid. Secondary symptoms you can see listed there: dyspareunia, abdominal vaginal discharge, chronic pelvic pain, avoiding sexual intercourse, an odor with abnormal blood loss, secondary unexplained infertility, secondary infertility despite ART, and other things as well. Now, before we come up with a diagnosis, a couple of things are required for diagnostic criteria. We need to get a minimum of 3 regular menstrual cycles before or after a cesarean delivery before the diagnosis can be made. A patient needs to be premenopausal before you can make a diagnosis. The complaints of symptomatic niche should start after cesarean delivery or should worsen significantly after cesarean delivery. And a patient can be cured of a symptomatic niche, though not all symptomatic niches do really need to be treated. So a lot of the times when patient comes with spotting, if we have diagnosed a niche and the patient is not worried about it, we can leave it alone. It does not require real treatment. Now, treatment can be conservative. We can leave them alone. Even a symptomatic niche can be left alone, does not require treatment. But if we are treating, our treatment is going to be either surgical, laparoscopically, or hysteroscopically. Now, hysteroscopically is purely for patients who are not planning fertility. Now, I've just got 3 cases to show you. The first was a patient who presented with infertility with one previous cesarean. So a lot of the times with these niche, we see that the uterus is adherent, is a uterus that's fixed to the anti-abdominal wall. And this is said to be one of the etiologies of the development of a niche. So when the uterus is stuck above, it doesn't allow proper healing, and improper healing allows a niche to develop. In these cases, you can use vasopressin to try to prevent loss, but most of the time, as long as you stay in the right plane, getting an avascular plane is not too difficult. So you can see in this case, along with the ovary, everything was stuck up and she had 5 years of infertility. The tube was involved in the adhesion and hence was far away from the ovary, and that could possibly explain the infertility that she's having. But also, cesarean scars have been are one of the causes of infertility. So even without any other cause, the fluid from a scar could affect fertility. So our first step is to get the entire uterus down. Now, most of these uteruses that are stuck above the bladder can be pulled up. In most cases, it is well down, and there is a peritoneal pocket that develops between the bladder and the adhesion. So our first step is to get the uterus down. So you can see we're dissecting into what we hope is an avascular plane. If you start to see bleeding while you're doing this dissection, it tells you that you are going into the wrong plane, in which case you could change the direction of plane. So here, as I was cutting, I entered into a small pouch, initially thinking that was the bladder. But then on further dissection, I found that to be just the peritoneal pouch. So once we dissected the entire uterus off, we found the defect. You can see what they call the sunset sign there, and the entire thinner portion of the uterus is excised out. Now, we want to cut through the entire thin portion. So if you've got a thin portion of myometrium defined, that means you have not yet got to the healthy portion of the cervix. So you have to get to a portion where the cervix is nice and thick. And we try to do a repair with a continuous suture in a double layer if the patient is planning for further pregnancies. If she's not planning further pregnancies, then just a single layer suturing is more than enough. The next case was a case of a scar pregnancy. I think Nayanaka already showed us a fantastic video of a scar pregnancy. But this is another one. So this is the hysteroscopic view. You can see the desdua thickened over there, sticking into the uterine cavity. So this is the picture that we can see. If the patient is not this side of fertility, this can be tackled hysteroscopically also, which was something that we considered in this patient. We considered tackling hysteroscopically. But because of bleeding, we decided to go laparoscopically to deal with the entire thing. So if a patient does not require fertility, you can deal with it hysteroscopically as well. So the first step is to dissect off the bladder. Again, being a scar pregnancy, if you would like, you could think of vasopressin, you could think of ligating the uterine artery at origin, but it's not something that we routinely do at our center. So first thing that I did was to dissect off the bladder completely. So we have to get adequate tissue both above and below the scar pregnancy, and only then will we be able to do an adequate repair. So first thing, like I said, making a proper dissection. You can see the nice bulging scar pregnancy there. We made an incision using the harmonic scalpel, cut into it, and then started to excise out the entire mass. It was a very friable tissue, and since we had already tackled a little bit of it from below, it wasn't coming out too easily from above. We tried our best to we couldn't get too much of it above. So whatever was remaining, we went down below and using a cannula, we suctioned out whatever was remaining, what we couldn't get out laparoscopically. Once the entire thing was removed, so we finished the removal vaginally at this portion. Once the entire thing was removed, there you can see the nice cavity. I want you to notice the cervical canal, the cervical layer here is quite thin. Now, this lady was not planning for the pregnancy, so we don't really have to excise too much more. We just had to incorporate that entire thin layer of the myometrium into the suture. But if there's a large thin layer, a person trying for pregnancy, it's not a good idea. It's a better idea to excise all the defective scar tissue before trying for a pregnancy beyond that. So again, using a barb suture, or you could use, I think Nayanaka used a vicryl, interrupted or continuous suture. The only important thing is to make sure you get adequate thickness in your bites to suture the entire thing closed. We suture the peritoneum above it to prevent, And that's the end picture of the procedure done. As you can see, this was the remaining bits. The last presentation that I have is a patient who presented. She's a 31-year-old who came to us with one cesarean she had done about a year and a half ago. And she kept coming back. This cesarean was after she kept presenting back to her primary doctor with discharge from the wound. As you can see, when we saw her, she had a collection just below the skin, so we did an incision there and drained the collection. It was just a thin serous fluid, palpating for an edema. We did a histoscopy at this point to see what exactly we were dealing with. And the histoscopy picture, as you can see, was quite clean. You could see both the ostia quite clearly. As we withdrew, we found one point at which there was a connecting cavity above. You can see the bubble sign of the fluid traveling of fluid showing your patent tract above. So we went above, and as you can see, this uterus also was slightly pulled up, though not very badly pulled up. First step, as always, is to dissect off the bladder and to show us the site of the defect. So here you can see this is the fistula that I have cut into. You can see the fistulous tract over there, the tissue over there. We cut our way further down, pushing the entire bladder off. So the first step that I'm going to do is to find the defect onto the uterus. Once I dissect that out, then we can proceed with the repair. So once I've taken enough of the tissue outside, I went back again hysteroscopically to try to see where the so yeah, that's me just dissecting off the entire bladder. I went for sharp, not an energy source, cold scissors to make sure that I didn't damage. This is a point again, I thought I had entered the bladder, but it was just a peritoneal pouch again. So again, dissection was quite easy here. So once I know that it's peritoneal pouch, it makes my work a whole lot easier. So that's a nice peritoneal pouch developed over there. And there, if you can see just over there, you can see my hysteroscopic grasper coming through, showing us the exact point of where the fistulous tract is. So once you know where the fistulous tract is, again, our procedure becomes quite simple. We didn't really require any vasopressin for this case, really. We just went ahead, excised the entire tract, and sutured the entire thing closed. Since this lady was planning further fertility, we sutured this in 2 layers to make sure that there is no further defect. That's the entire thing closed. Now, she did have a connection, like I told you, so we had to excise the fibrous tract above as well. So we started to enter into the cave of Retzius, and then we just shaved the entire tract off the bladder, and then sutured again. We didn't have to, but we sutured the cave of Retzius closed. So that you can see the finished picture. So the most important thing that I think that I would like to leave you all behind with is prevention is more important. So try to prevent the first C-section. If you have to do a C-section, proper uterine closure with proper surgical techniques, tissue handling and hemostasis and asepsis. Repeat CS means more trouble. Thank you.
Thank you very much, Tarun. It was a very exhaustive one and a very complete one in terms of your cystic scar defect. Like about some tips as to the preventive aspects. You've told about closure in 2 layers. Anything else that you would like to share with us in terms of preventive one? Because nowadays we are picking up a lot of cases. Picking up a lot of cases. Probably you need to do better ultrasound in the first trimester, better techniques. But then, what exactly would you like to suggest regarding the preventive aspects?
I think it's whether you do a single layer or double layer closure, a full thickness closure is what is important. We need to make sure that we get adequate myometrial tissue, the volume of the tissue into your suture line is what's most important. So whether it is single layer or double layer, follow what you want, but make sure you do it properly.
Thank you very much, Tarun. I think I have to appreciate you've given a very, very exhaustive academic talk. But besides your academic talk, we've always been very appreciative of your talks, for the common man and common public. You have always been a regular speaker on Sun TV, Vanakkam Tamila, and also in Taylor and Circus. It's a good thing. We need to go back to the public, and disseminate our knowledge about it.
Thank you, sir. Thank you so much.
Appreciate your work on the public awareness aspect also, Tarun. Thank you very much.
Thank you, sir.
So we now come to our last speaker of today's evening, but last but definitely not the least, Dr. Yashodhan Deka, who speaks on deep endometriosis enigma. And just 3 days back, we witnessed his fantastic surgery on deep endometriosis in Peerless Hospital, Kolkata. So Dr. Yashodhan, he has an advanced laparoscopic fellowship in Kochi, New Delhi, and Ahmedabad, and he has been an operating faculty in various national and international workshops. He's currently consultant laparoscopic surgeon at Nalbari Maternity Hospital and Sarthi Hospital. Welcome, Dr. Yashodhan.
Yeah, Dr. Pashali, as you said, MS Dhoni is on the way, The finisher is there.
I don't know why my video is not running. Should I start my screen sharing though? Hi, Dr. Subhash, how are you? Long time.
All good, bye. All good, bye.
So can I start my screen sharing?
Yeah, please.
So first of all, thank you, Bhaskar sir, for this wonderful opportunity, and I hope you can see my screen. If not me, but my screen at least.
Your voice is good enough for the whole country, bye.
So all the machos have already presented, so I'm at the fag end. I hope everybody is at least looking into it. So I'm going to keep it very crisp since we are at the end of it. Is my presentation visible?
Yes,
Dr. Yashodhan. Yes.
Okay. So, of course, deep infiltrating endometriosis is a very vast topic, but I'll keep it crisp to the bowel endometriosis bit because I have only, I think, 10-12 minutes. So, this I know everybody shares, so this is exactly what it is. And we all know how endometriosis can be classified. And bowel endometriosis is actually a big number, 12%. And actually, we have, I would say that 80% of our cases of endometriosis have some sort of deep endometriosis. This is what it looks like on an ultrasound on a regular transvaginal scan, and this is what it actually looks like when you actually cut it out. So you should be aware when you have severe dyspareunia, abdominal bloating, could be hematuria is of course dysuria. This is the urinary bit, but if there's radiating pain, there's perineal region, there's gait abnormality. Why is it challenging? Is because there's infiltration beyond what you can see. There's involvement of retroperitoneal structures. There's retraction of surrounding structures, gross anatomical distortion, and is often missed out on routine screening. So there are various classifications that are there, but I think now we all know that hashtag enzyme classification is what is to be followed because this is the only classification that correlates with deep endometriosis, and you should do a preoperative and an intraoperative classification of this so that whenever you operate, at least when the patient goes somewhere else, they can understand what you've operated and what you found. So investigations, we all know ultrasound, if you're good at it, you can really pick it up very well, but MRI is definitely the gold standard. So lesser known facts, medical treatment does not cure deep endometriosis and pregnancy does not seem to prevent disease progression. This is something that we should all know by now. And moreover, it is associated with prematurity, hospitalization, and low birth weight. This is a very, very interesting article, and all of us should definitely go through it. Where now this is an excellent detailed article where they are actually talking about lateral rectal ligament and rectovaginal septum on transvaginal sonography. So very interesting. So when we come to surgical management, it basically divides into conservative and radical. Conservative is shaving and discoid, and radical is of course segmental. So we should know when should we go for a discoid versus a resection, and the criteria are now pretty much very crisp. When the lesion is less than 3 centimeters for a discoid, depth is less than 1 centimeter, and a single lesion volume of less than 7 centimeter cube. Why does volume and centimeter? Is because we should know that when we use a circular stapler for a discoid excision, we should know there are different sizes from 29 to 31 to 33, and we should know that what volume of tissues they can actually retract. Only then we'll be able to pick up the correct size. And for segmental, of course, if it's a big lesion, if it's occlusive, if there's multiple lesions, and if there's circumferential involvement more than 50%. So this is a scan that is done by ourselves in. So you can see the bowel nodule very clearly. You just slide your probe behind the cervix, go to the posterior fornix, and you can see the rectal nodule very nicely. So take it in two sections because you're supposed to measure it like how I'm showing you right now. This is the entire length of the nodule traced, okay, and then we see the depth of it, and this is the transverse because this is really helps you to counsel the patient. So this is more than 3 centimeter, so definitely a segmental. So you should have your correct team, you should have the correct weapons in your theater to deal with such situations. And this is a, oops, did not play. Sorry about that. I think I just need to play it from here if it's not showing. It was playing. Just give it 2 minutes, it's loading. So this is a very simple case of a deep endometriosis where the lesion was typically less than 3 centimeters, and it's very, very typically missed on routine scans because the uterus and the ovary was normal. This was a surgery that we relayed live on to Jaipur, I think. So a typical scan where the uterus and the ovary is normal, but the patient will tell you. So listen to the patient, listen to what history she is giving you, and don't be blindfolded to the pain, and don't make pain a very blanket statement. So she has a lesion that is less than 3 centimeters. The first thing you need to do is go laterally. So I call this the ultralateral approach, where you mobilize the sigmoid as laterally as possible, and then you just flip the sigmoid. Once you flip the sigmoid, the first structures that will appear in front of you is the infundibular pelvic and the ureter right in front of you. So ureters, of course, we have to safeguard, and we have to make sure that is lateralized from the lesion. These are just very important safety measures. So endometriosis, we all know now, it's a very mathematical surgery. I call it the mathematics of endometriosis. And if you follow these surgeries, and we demonstrated such in Kolkata very recently, where if you follow these mathematics, it is just a walk in the park. So you first do ureterolysis, and then you create a pararectal space. You have to understand the concept of creating this pararectal space. Then we just simply uh, suspend the ovaries. You can use a T-lift. We use a simple port closure to do that. Similar steps are repeated on the opposite side. But of course, the ergonomics change a bit because you're on the opposite side. And since we're an ipsilateral surgeon, make a small hole in the pelvis and you let the carbon dioxide enter. Once you do that, just nick the peritoneum with the tip of your instrument, any harmonic scalpel that you're used to, identify the ureter, lateralize it completely because it has to be away from your field of dissection. Keep going, lateralize it completely, and then you again develop the pararectal space. And I always say that whenever you are attempting difficult surgeries, I think a 3D technology is definitely beneficial. Your speed increases, your patient safety increases, and your accuracy increases a lot. So then you create a pararectal space. Till now, you can practically see no lesion in the bowel, but we have picked this lesion up, and she is symptomatic for the bowel. So listen to the patient. That is what is most important. She might have a routine. She might have a routine. The ovaries and the uterus might look normal. So then you develop. So I call this a push, open, push technique. Just push, open, and push, open, and push. Okay. Somebody has named it the POP technique. It's very interesting. And then we come to the part where we have to dissect the bladder, the bowel from the uterine torus. At this point of time, we like to switch over to simple bipolar incisors because for two reasons. The bipolar buzz keeps the field bloodless, and when you cut with the scissors, you can actually feel when the nodule is coming. And and I feel that always when you cut with a scissor, it's just a much more clean cut, a cold cut. And even if you injure the bowel at this point of time, of course you can repair it without any problems. And when you cut with the scissors, you can actually feel it. You can navigate yourself through the tissues because after doing a lot of endometriosis cases, you will realize that even if your imaging was not apt, even if your imaging was not up to the mark, but you can just follow the tissues and identify it. And if you have an excellent imaging system, literally you just follow the fat because the involved fat looks different from a normal fat. Okay. So as you can see now, this is where we are approaching the nodular part here. So stay flush, flush, flush. The uterus is actually acutely anteverted with a vaginal manipulator, and we usually suspend both the ovaries on the side. Now with your pararectals space dissected, you are only left with the nodular part in the center. That is the importance of doing a pararectal space dissection, where you can actually see, okay, and then get a nice pull on the bowel get one of your assistant to give a cephalic traction to the bowel and just give small nips and proceed millimeter by millimeter with a slight buzz, because this is the nodular area. We used to use vasopressin in these areas before, but now we have realized that vasopressin actually gets you lost in the tissue planes. So it is better that you just continue with your regular, see the rectovaginal space, you're right open, because in such spaces actually bleeding helps you guide where you have gone. If it is bleeding, that means you've gone in the wrong plane, because a nodule does not bleed. So if you're bleeding, that means either you're going into the vagina or you're going into the rectum. So that guides you that maybe you're just millimeters or inches, plus and minus there, and it really helps you. So we have stopped using vasopressin at any steps for endometriotic surgeries. Earlier, we used to think that okay, maybe your the field is more bloodless and it helps you lessen the bleeding, but I don't think it does. I think it practically takes you in the wrong plane sometimes, and I think it's a false sense of security to use vasopressin at this point of time. So you just keep go on cutting. You identify the rectovaginal space. If at this point of time, sometimes when the vagina is also involved, then what you have to do is you put a finger in the vagina, feel the nodule, and then cut it through. Okay, so that's the entire nodule. You can palpate it, see how I'm not able to close my instrument, and then you have to do good bowel shaving. So nowadays you have a new ultrasonic probe that has come into the market, which is a 10 probe, and you can actually introduce it into the patient abdomen using your 10 probe, and you can trace. It is a very good technique, a very good technology, especially if you do a lot of shaving. In our center, we don't believe in a lot of shaving because I feel shaving is not a standardized technique, and with shaving, you can never know how much you've left behind. And after deep shaving, particularly, I'm very insecure about leaving the bowel open with such less muscularis and serosa on top. So we feel that if it's a small lesion, better to go for discoid than go for shaving. But even if when you do a discoid, the principle is again going back to the volume of the stapler that the tissue can accommodate. So make sure that the lesion is extremely thinned out so that the amount of tissue that has to be taken in the staplers is very little. It cannot be more than 7 millimeters or 10 centimeter cube, because that is the maximum amount of tissue a circular stapler can accommodate between the anvil and the stapler. So you have to keep a check on that. Earlier, yes, the limitation was 3 centimeters, but now we have seen that we can go beyond 3 centimeters also, provided the lesion is very well shaped. And instead of taking a single stitch, which we will see at this point of time, you can take a double stitch. And in some cases, we have even done a double discoid, because bowel endometriosis is actually very tricky. These are guidelines, but what you face practically intraoperatively can be totally difficult. For example, tomorrow we are operating a case with a uterosigmoid fistula. She was operated before with a bowel injury and she developed cyclical hematochezia. And she also has a very long rectal nodule, which is about 3 to 4 centimeter. So anyways, coming back to the video, we have to take a bite at the distal end and then in the cephalic end of the lesion. Now the lesion is in between these sutures, and then you pass a circular stapler from below and you open the anvil up, and once you tie the knot, the lesion will come in between your anvil and the stapler. When you tighten it, you just push it down. Once you push it down, anti-vert the stapler, because in a discoid dissection, the most important part is that we should never have the posterior wall into the stapler. So once you do a anti-version and close it, make sure the rotation of the bowel is correct. And once you see that the rotation is complete, and pray to God and fire the stapler. Okay, you can see that it's beautifully approximated. Absolutely clean pelvis now. You can actually see the hypogastric nerves on both the sides. A good ureterolysis done. And this is the end of the surgery. Similarly, in this surgery, we have already done the required dissection. Although the size of the lesion appeared small, but what has happened is that the lesion was subocclusive. So once you have dissected it completely, we have mobilized it completely, and you have to defat it. So what is important is that when it after you defat, so wherever, even if you're prepared for a discoid, what you have to be sure is sometimes you never know situations like this where you have to convert a discoid to a segmental resections. So whenever you counsel a patient for discoid, also you should be prepared for segmental, because in this particular case, the lesion was small, but it was subocclusive because like we could not pass the circular stapler through it. So intraop, you have to convert it to a segmental. So make sure the bowel preparation is correct, and then you just open the distal segment up. Once you open the distal segment, I will show the steps in a very crisp manner. Make sure there's a suction there, because if there's stool, then you have to suction it out. But look at this, the bowel preparation is excellent. We are still believer of a mechanical bowel preparation. We put the patient on 2 days of liquid diet prior to admissions, and liquid diet can be as simple as dal, soup, ORS, milk tea, and the patient comes in night before the surgery and give a good soap water enema at night, in the morning, and in the afternoon before we take up the patient for the surgery. And the bowel preparation is just excellent. We are almost close to 90 bowel resections now, and by God's grace, we haven't faced an incidence of leak yet. So then this is the nodule that we are holding. This is the proximal part. You have to palpate it, and then you divide it, and so you divide it completely, and then you deliver the segment through the rectum. So that is a natural orifice specimen extraction where there is no laparotomy done. Then you introduce the anvil through the rectum. The distal staplers are fired. It's very challenging at times because the uterus, because the space in the pelvis is very narrow. Then you introduce the anvil into the proximal segment. Once you introduce it to the proximal segment, make sure assistant is holding the bowel stable. Make a small nick by an ultrasonic scalpel or a monopolar, whatever you're comfortable with. You introduce the anvil into the proximal part, and then you close it by a linear stapler. So this is an end to side. So yesterday we did two bowel resections, where in one case we had to do a end to side, and in one case the resected segment was almost about 5 to 6 centimeters. So we had to go for an end to end because the mobilization was not adequate. So once the proximal segment has been ligated, the circular stapler gets introduced from below, and then you just make sure that the anvil is fitted on without any rotation of the bowel. So make sure that the bowel is rotated in a correct manner and the anterior surfaces are matching to each other. And this patient is doing extremely well, and she's up for ART in the next month. So you fix the anvil, and once you fix the anvil, make sure rotation is correct, make sure you have enough bowel mobilization, and then do a bowel check in the end, the Lee test. The complications can be fistula to rectal rage, stenosis, ischemia, chronic constipation, neurological damage, which can lead to neurological bladder. So you have to watch out for the nerve. There are very high post-operative fertility rate following surgical management of colorectal endometriosis. A skilled surgical management for symptomatic large deep endometriosis nodules infiltrating the rectum in young women is followed by a high pregnancy rate 4 years after the surgery. This is a published article by Horace Roman. Also, reproductive and post-surgical outcomes of infertile women, where they have shown that post-operative pregnancy rate with women with deep endometriosis was 61.82%, huge number. Horace Roman also showed that it's a progressively increasing chart, and by the end of 4 years, the rate of achieving pregnancy was 86.8%. There's also high post-operative fertility rate following surgical management of endometriosis. Thank you.
Thank you. Thank you, Yashodan. Yeah, Yashodan, there's a question for you from Dr. Surakshit. Vishali, can you just...
Yes. Yes, so what are the counseling you will be giving regarding post-operative bowel issues that occur due to the surgery? Because he has written that they might have constipation before surgeries. So what bowel issues do they have after the bowel resection? And what management do you provide them? So counseling regarding the issues and the management.
Yes. So first of all, of course, you have to take a consent for a post-operative redo surgery or a colostomy in case of any leak, because nobody can say that there's not going to be any leak. Secondly, when you operate a segmental resection or a discoid, one very important thing you have to counsel the patient is that post-operatively, patient is going to have a change in her bowel habits. The change will be in terms of multiple times she'll have to go to the loo. The stool consistency might be normal. I have had a patient who had frequency up to even 20 times a day, and it lasts for quite a while. It can be very distressing for the patient and the doctor, but if these things are counseled preoperatively, it is much better handled. Secondly, bladder is something that is not to be ignored even when you're doing a bowel resections, because there's an article published way back in 2015 in Journal of Minimal Invasive Gynecology, which shows that the increase in the size of the bowel nodule is directly proportional to the invasion of the parametrium and hence lead to ureteric involvement. So when we have a very bad case of bowel endometriosis, make sure that patient is also counseled about urinary retention. If the patient fails to pass urine 4 hours after removal of catheter, the next day she has to go for an ultrasound where you have to look for a post-voidal bladder volume residue. And
Yeah, okay. May I invite Dr. Bhaskar sir for the
No, I
concluding?
have nothing to say. Subhash, you and Kaushal to close. Thank you very much. I think it's been a long webinar, so 3.5 hours. But I think it was great showcasing to work. But I have just as we say that we said right at the start that generation after generation are technically more gifted. But I think apart from surgical skills, there are two more things to see is that when to operate and when not to operate. So that's just a word of caution that we choose our cases and we treat the patient's symptoms and not only the disease. So tailor the treatment to her symptoms and what she is aiming at rather than trying to eradicate diseases all the time. But I'm really grateful to all of you. Thank you very much.
Thank you, sir. Thank you very much for that pearls of wisdom, sir. Anyway, thank you to all the speakers for the efforts and time that you have put across. And Poshali, thank you very much. You've taken a lot of efforts in this particular session. It's always it's a big task, and today's was a big one because you had a lot of people to be involved, and I really appreciate Poshali for all your hard work and dedication for this. Thank you very
Thank you so much, sir. Thank you.
And finally, thank you to Alembic and thank you to Conference International.
Thank you, everyone. Thank you. Thanks a lot, sir. Thank you,
Thank
Bhaskar.
you. Thank you to all the chairpersons, Bhaskar sir, to all the speakers, and to Conferences International Alembic, and to all the audiences who have viewed. Thank you. It was a wonderful session. And we meet till we meet. Goodbye from all of us. Bye.